posvećen obilježavanju Svjetskog dana srca i 75. rođendanu Svjetske zdravstvene organizacije. Znači 75 punih godina. Ove godine moto Svjetske zdravstvene organizacije je zdravlje za sve. Čestitam vam Svjetski dan zdravlja, 7. april, i ujedno vam čestitam i vjerske praznike koji nam predstoje ili su u toku. Pesah koji se obilježio prije 2 dana, Uskrs, Vaskrs, Ramazanski Bajram koji slijedi nakon ovog mjeseca Ramazanskog posta. Otvaram redovnu godišnju skupštinu Udruženja kardiologa HNK. Materijale ste dobili u elektronskoj formi. To su izvještaj o radu Udruženja kardiologa HNK za 2022. Finansijski izvještaj i plan rada za 2023. godinu. Do sada nismo dobili nikakve primjedbe niti dopune materijala koje smo vam dostavili. Ako ima sada neko od članova udruženja da dopuni ili da komentariše, izvolite. Čujemo li se? Čujemo li se? Ukoliko nema, ja bi se dao ove materijale na usvajanje. Ukoliko nema primjedbi, možemo, i niko se ne javlja, možemo zaključiti da su materijali skupštine prihvaćeni u onom obliku u kojem su i dostavljeni. Zahvaljujem se svim članovima udruženja koji su poslali svoj izvještaj o radu. Posebno želim da istaknem profesora Rumbolta koji je, iako penzioner, dostavio svoje aktivnosti tokom svog penzionerskog perioda. Time bi ovaj oficijelni dio skupštine završili. Još imamo ovih 8 minuta linkovanja. Želim da pozdravim Emira Veledara iz Mijamija, da mu se zahvalim na angažmanu i da poželim uspjeh u vođenju, jer će on voditi prvi dio sesije sa kolegama iz Amerike i Indije.
Okay, whenever you want me to start, I will start. So, surprisingly enough, this wasn't typical Balkan meeting. The first part happened on time, even before. So, we supposed to start at noon, or what are the references? Are we going to start at noon? Hoćeš da počnemo u podne?
Pa tačno u 6, jeste.
Yeah. Okay, so for next 5 minutes...
Imaćemo samo pozdravne riječi ovih pokrovitelja. Evo, pošto sam se ja već javio, budući da profesor akademik Asim Kurjak, predsjednik naše Internacionalne akademije Bosne i Hercegovine, me ovlastio da pozdravim ovaj simpozij u njegovo ime, u ime Internacionalne akademije nauka i umjetnosti, a ja kao predsjednik ovog regionalnog odbora Akademije u Mostaru, evo želim da vas pozdravim u ime Akademije i kao potpredsjednik Vijeća Kongresa bošnjačkih intelektualaca Mostar, želim da vas pozdravim u ime predsjednice Elbise Ustamujić i u ime vijeća. Također bih želio da istaknem da je ova saradnja unazad nekoliko godina vezana je za aktivnosti pojedinih članova našeg udruženja i u ovim asocijacijama. Time su podigli nivo naših prezentacija na simpozijuma, a i nivo samog simpozijuma. Zamolio bih predstavnika Zavoda zdravstvenog osiguranja HNK, koji je, ne znam da li je linkovan. Zoran Kazazić se linkovao davno. Zorane, jesi li tu?
Ja vas čujem dobro, nadam se vi mene.
Ajde, Bujrum, obrati se skupu. Dobro nam došao i hvala ti.
Hvala vam lijepo. Ovako, kao i svake godine sam prisutan tu da pozdravim članove radnog predsjedništva, ostale dame i gospodu koji su se uključeni već u vaš link. Dozvolite mi evo i ove godine da vas pozdravim u ime direktorice Zavoda zdravstvenog osiguranja Hercegovačko-neretvanske županije kantona, dr. Ane Vidačak, i u svoje ime. Evo i ove godine smo sa zadovoljstvom odazvali pozivu da budemo jedan od pokrovitelja, sponzora ovog vašeg internacionalnog naučnog simpozijama koji se organizira povodom Svjetskog dana zdravlja 7.4. ove godine u Mostaru. Imamo za to više razloga, ali navešću samo neke od njih. Mi smo institucija čija je misija da osiguranicima našeg kantona omogući kvalitetnu, efikasnu, integriranu zdravstvenu zaštitu. Da bi to postigli neobadan je stalni razvoj partnerskih odnosa sa davateljima usluga. Drugim riječima, mi smo na istom zadatku, pošto nam je zadovoljstvo osiguranika i unapređenje kvaliteta zdravstvene zaštite i usluga u prvom planu. Imajući u vidu činjenicu da su kardiovaskularne bolesti jedan od najvažnijih pobola smrtnosti, radi na svaki novi napredak u ovoj grani medicine. U odnosu na sve naprijed rečeno, ovom simpoziju danas želim uspješan rad i drago mi je da neke drage likove koje dugo nisam vidio danas vidim. Ujedno koristim ovu priliku da izrazim duboku zahvalnost vama, doktore Emire Begović, i svima drugima koji zadnje 23 godine predano rade na razvijanju i promoviranju svijesti onome što predstavlja zdravstveni stilovi života i uključivanje što većeg broja omladine, sportaša i ostalih građana grada Mostara u nizu sportsko-rekreativne aktivnosti. Želim vam još jednom uspješan rad i hvala vam na pažnji.
Hvala Zorane. Zahvaljujem se još jednom zavodu koji je naš tradicionalni pokrovitelj i sponzor naših aktivnosti u gradu i u Hercegovini i stalno je podrška ovim našim aktivnostima, a mi se trudimo da odgovorimo zadatku koji smo sebi postavili. Pozdravljam naše prijatelje iz Indije, profesora Prabhakharana, zatim pozdravljam naše prijatelje iz Amerike, Arshada Ujumija, pozdravljam Amita Šaha, Anšula Saksenu, Munija Rubensa i Petera Magrandhana, koji će nam se obratiti večeras kao učesnici ovog našeg simpozijuma. Profesor Prabhakharan, dobrodošli, molim vas da prezentirate vaš rad i molim Emira Veledara da nastavi voditi simpozijum. Počuli na engleskom da vam first of all, Professor Dr. Emir Veledar from Miami, who will be the chairman of the first part of the symposium and who is the main organizer of our friends in USA, that Professor Dr. Prabhakharan Doyaraira from Delhi, India, World Health Federation, who as a representative of World Health Federation, he been attending out gathering for years. Professor Prabhakharan, welcome and please present your work. I ask Emil Veledar to continue leading the symposium. You're welcome.
Okay, Dr. Prabhakaran, you are our returning speaker. We already had the pleasure of to see you more than once in this conference. So whenever you're ready, start with your presentation. You are muted.
Right. So good afternoon or good evening, good morning to everyone, and thank you all, and thank you, Professor Emir, in particular, for inviting me to give this talk. I think to share my slides, I will need that you provide me control, I suppose. Let me try.
Okay.
So you have to give control actually to me, because it's not allowing me to present. Let me try again. Can you see my slides?
Yes, we do.
Yes, we do.
Oh, okay. Right. Okay, let me start off by thanking everyone, and it's such a pleasure to come back and give this talk during the World Health Day. I have titled my talk as Emerging Themes in Cardiovascular Disease Prevention. So the question is, why am I talking about this? So when we look at risk factors for coronary artery disease and cerebrovascular disease, as clinicians, we know that we are all aware of this modifiable and non-modifiable risk factors. We have basically behavioral risk factors such as tobacco, diet, physical inactivity, and stress, and biological risk factors such as high blood pressure, diabetes, dyslipidemia, and central obesity. And of course, we also know that there are certain non-modifiable risk factors such as family history, age, gender, ethnicity, and genetics. But there are also conditioning factors such as poverty, education, stress, life course, socioeconomic status, and fetal programming. We now know that it's a disease that occurs across the lifespan, and the risk is determined even at birth, and therefore we need a life course approach. And to that, we have added several environmental pollutants such as air pollution and others. So when we look at emerging themes in cardiovascular disease, we can actually put them into three big buckets. One is to look at new and emerging risks, such as new understanding of lipids and diabetes, the role of environmental pollutants, and the role of emerging infections, particularly, for example, COVID. There are several innovations in care that have happened in the last decade or so, which includes task sharing and shifting, that is, shifting some of the tasks from a higher level healthcare, like from a cardiologist to a primary care physician, or from a primary care physician to a nurse or a community health worker. We can also look at some of the technologies which are affordable, the telehealth and telemedicine programs. We have some innovations in terms of improving compliance using fixed dose combinations of polypill. We do have some innovations in behavior change and the whole range of implementation science that is required to increase the uptake of evidence-based care for cardiovascular diseases. In terms of innovations in research and future directions, we have technology-based solutions for clinical trials. There's something called co-design interventions, which is coming up, where we talk to patients, we talk to communities and design interventions. And there are some other highly advanced programs like interoperability, blockchain technologies, and so on. I'm not going to talk about all of these, but I'm going to give some indicator examples of what we need to understand. First, I think there is a paradigm shift in the understanding of the mechanisms of cardiovascular disease. Number one is when we look at lipids, we all know what an LDL particle does. We measure LDL, the amount of LDL in our blood, and say that it's very high or low. And if it is high, we give them statins or we provide them even with the newer drugs like PCSK9 inhibitors and several others. But when you look at the structure of an LDL particle, it's somewhat like this. So it has a polar surface coat, which has phospholipid and free cholesterol. And on the surface, we have these apolipoprotein B particles. And inside the LDL particle is non-polar lipid coat, which consists of cholesterol ester and triglycerides. But LDL particle is not homogeneous. It's not a single type of particle. There are three types of LDL particles, which are classified as types 1, 2, and 3. Now, type 1 is a large particle, type 2 is intermediate size, and type 3 is small particles. So what really happens when you have small particles is they get densely packed, but the atherogenicity of LDL is because of this surface protein called apolipoprotein B. So a combination of apolipoprotein B and triglycerides can actually increase the risk of atherosclerosis, and a lot of understanding has come up on this basis. I'm going to give the examples of Indians, but it can be applicable to other populations too. Now, Indians, in comparison to other ethnic groups, for any given level of total to LDL cholesterol, have a high level of total cholesterol to HDL cholesterol ratio, because HDL cholesterol ratio in Indians is lower. But in addition, they have high levels of small dense LDL fraction, which increases the atherogenicity of the lipid pool. So when you look at it, is it related to the mass of cholesterol, which is what we measure? When we measure lipid profile, we measure total cholesterol, we measure LDL cholesterol, we measure HDL cholesterol, and sometimes we actually calculate LDL cholesterol based on total cholesterol, triglycerides, and HDL by the Friedewald's formula. So is it important to measure the total mass of the particle or the number of particles? Because the ApoB particles on the surface is highly atherogenic, as I said, and every LDL particle carries one apolipoprotein B particle, and therefore when you have small dense LDL particles, you have more number of apolipoproteins. And a combination of high triglycerides and high levels of ApoB increase atherosclerosis. So the question is this true? And it has been shown in the Interheart study that South Asians, for example, but there are other populations too, and I'm emphasizing that point, that South Asians, as compared to other countries, have very high levels of ApoB. In fact, when you look at other risk factors, they are very similar, whether you compare, when you compare South Asians to other countries. For example, smoking, there's no difference. Hypertension is lower in South Asians, but given that it's self-reported and given the fact that the awareness is poor, so it appears to be lower. But diabetes, again self-reported, even then it is slightly higher in South Asians as compared to other countries, and waist-hip ratio is somewhat similar. So clearly indicating that ApoB to ApoA1 ratio, ApoA1 is present in HDL, which Dr. Arshad Qayumi will talk about, and essentially saying that high ApoB levels are an important cause for atherosclerosis in South Asians. So we had an opportunity to compare ApoB and LDL cholesterol level in Indians and compare them to the population of United States using the ENHANCE study. And when we did a comparison, the ApoB levels were higher in Indians, the triglyceride levels were higher in Indians, but the total cholesterol level was higher in the United States population. The non-HDL cholesterol was somewhat higher in the United States population, and the LDL cholesterol was higher in the United States population, and HDL cholesterol was lower in the Indian population. So one point that we can really make out is, if you measure LDL mass, it is definitely higher, and it is curiously lower in the Indian population. But when you look at ApoB, because we have high levels of small dense LDL amongst Indians, ApoB levels are higher in Indians. Now, this is not true of one particular age group. It is present across all the age groups except in the older age groups. That LDL cholesterol is higher in the US population, and ApoB levels are higher in the Indian population. Now, this has been shown in other populations too, and when studied, several studies have suggested that ApoB is a better predictor of future myocardial infarction as whether you take LDL cholesterol, whether you take non-HDL cholesterol, whatever you take, ApoB is an important predictor of future myocardial infarction. Therefore, the question is, should we move away from measuring LDL cholesterol and should we start measuring ApoB particles? The reason is ApoB is a single atherogenic lipid marker present in all lipid subfractions except HDL cholesterol. And ApoB integrates, as I showed you, it integrates and extends the information from triglycerides and cholesterol. And given the complexity of conventional lipid panel, that means when you're doing a lipid panel, you measure total cholesterol, you measure LDL cholesterol, you measure HDL cholesterol, triglycerides, and VLDL cholesterol. But if you're going to do, you have to measure only one factor, and that would be ApoB. And there are several studies that includes Mendelian randomization studies, AI-based analysis, and even clinical trials have shown that ApoB to be superior. So my personal feeling is in the next few years, we should start moving to using ApoB as a screening tool. So that's the first thing about lipids. The second question that I want to pose is, do we know enough about diabetes? Now, when we talk about diabetes and we ask anybody, even people who are sitting in this webinar, when we ask them, they will say diabetes is because of lifestyle change. Because of globalization and urbanization, there is lifestyle change, which results in overweight and obesity, particularly in a genetically predisposed individual, which results in increased secretion of insulin, resulting in insulin resistance, and ultimately resulting in diabetes and impaired glucose tolerance. Some people may say, no, it is all genetic. But is this true? Is this true within populations? Is it true across population? That's a question we need to pose. So when you look at an ecological comparison, these are data from the World Health Organization. And this is little old data, but it makes an important point. When you look at overweight and obesity in the United States, nearly 2/3 of the population is overweight or obese, whereas the diabetes prevalence in this population is only 9%. In China, at that time, the overweight and obesity prevalence was 30%, and diabetes prevalence was 9%. And in India, overweight and obesity at that time was only 13%, and diabetes prevalence was, surprise, it was 9%. How is it that if you're going to use the BMI as a criteria, if you're going to use overweight and obesity as a criteria, how is it that the prevalence of diabetes is equal in United States, China, and India? So one might argue that there is something spurious here. There must be some error, something different. Where when we do an ecological comparison, there are a lot of biases involved, and therefore we should look at within the United States and see where you have a multi-ethnic population, make a comparison and see if this is true. So Professor Venkat Narayan, who's my colleague and his PhD student, looked at this precisely. When they did a comparison of several ethnicities living within the United States, the biggest observation was amongst people who came from the Indian subcontinent, even amongst those who had normal BMI, they had almost 2 times the prevalence or 3 times the prevalence of diabetes. And as they put on more weight, the diabetes prevalence virtually shot up. So clearly suggesting there is something else which is happening amongst the South Asian population. So they did a comparison again, another of his colleagues, Lisa Steiners, and he made a comparison of Pima Indians in the United States, who are best example of exemplars of diabetes in the world. Because the reason that we talk about obesity as a cause of diabetes came from the Pima Indians. So they compared Pima Indians to people of to Asian Indians, that is Indians living within India, coming from the city of Chennai. When they looked at the prevalence of diabetes, it was 50% by the age of 55 years amongst Pima Indians, but amongst Asian Indians, it was 50% by the age of 55 years. So it was very similar. But when they looked at the obesity profile, Pima Indians were very obese, whereas Asian Indians were relatively thinner. You can see the numbers here. BMI amongst Pima Indians was 33.7, whereas BMI in Asian Indians was 25.7. When they looked at glucose profile, Pima Indians had higher 2-hour plasma glucose, whereas Asian Indians had higher fasting plasma glucose. In terms of pre-diabetes distribution, more than 2/3 of Pima Indians had impaired glucose tolerance, whereas more than 2/3 of Asian Indians had impaired fasting glucose. And when they looked at insulin resistance versus insulin secretion, Lima Indians had very high levels of insulin resistance, whereas Asian Indians had very low levels of insulin secretion, suggesting that there is a differing mechanism in terms of diabetes. So in the future, instead of one homogeneous type 2 diabetes, we may possibly have a type A and type B diabetes because treatment differs. As a clinician from India, I know it's extremely difficult to control fasting blood glucose in Indian populations. You may have similar patients in your practice, and so there may be a different mechanism, and then they may require different drugs. So we might get an answer in the next few years with regard to this. And there are many other reasons why people could have high risk for diabetes. So we looked at the role of DDT, which is a pesticide, and incident type 2 diabetes in urban India. And we found that indeed the DDT metabolite DDE is higher amongst people with diabetes as compared to controls. But when we controlled for age, it disappeared. Unfortunately, we didn't have enough power to look at age interaction. And I personally believe that this could be one major factor. And there are many other unexplored pathways. And so we believe that when we look at diabetes, there are many unaddressed research questions. Could it be a poor beta cell function and capacity as we find in the Indian population? Could it be early life influences, low birth weight, fetal undernutrition, increasing the risk of diabetes as adults? Could it be hepatic insulin resistance, the presence of non-alcoholic fatty liver disease, and so many others, including air pollution and so on? So these are some very interesting questions that need to be answered as we go along. So if you have to identify cardiovascular disease, what is needed is we need to move away from the etiological model, which we have been talking about, that with the risk factor model, but we need to look at early life developmental model and combine both these and talk about what we call as a life course model. So there are multiple factors across the lifespan which increases the risk, and therefore we need to look at both risk factor as well as early risk, because risk accumulates across the lifespan and it is a combination of both biological and social risk factors. So we are programmed individuals, be it genetic, be it because of fetal programming or epigenetic changes or early life determinants. And whenever we have certain environmental triggers, for example, smoking, high salt intake, trans fat intake, we can get cardiovascular disease. Secondly, the programmed individuals can develop intermediate phenotypes with metabolic abnormalities, which would again increase cardiovascular diseases. Lastly, people in our parts of the world have a higher cardiovascular mortality because of several reasons that includes biology, personal beliefs, life course, socioeconomic status, air pollution, and including the health system response. So this is as far as the etiology. I just showed you two examples. There are multiple other examples in terms of understanding the mechanisms of cardiovascular disease across ethnicities. Now I'm coming to the second part of my talk. We know what causes cardiovascular disease, but we really must do something about it. And the big problem is that we are not doing enough. So we really require innovations. And the first innovation that is required is that we need to keep a good count and we require a good surveillance system. So in effect, we have several methods that are available now in terms of technology for both surveillance, screening and diagnosis, and for management, and even for clinical trials and several other research aspects. We'll not talk about all of these, but I'm just going to show one or two examples once again. Now, we all know post myocardial infarction or post stroke, we have several inexpensive but effective secondary prevention drugs. We know that lifestyle modification, particularly tobacco cessation, dietary modification, physical activity, and stress reduction can actually improve outcomes in people who have had a myocardial infarction or a stroke. But when we look at the treatment cascade, the secondary prevention treatment cascade, we think that if we provide them all the advice, the right drugs plus the lifestyle advice, the efficacy is almost 75%. Because not everybody accesses healthcare, there are some interventions which may be inadequately prescribed by healthcare professionals, and poor patient adherence. The real effectiveness comes down considerably. From an expected 75% efficacy, the real effectiveness is just around 20%. So what can we do about it? One of the things that we know, this is real common sense. When we advise people to modify their risk factors, they don't do, because when the whole family, for example, has a different way of activity, or it's very difficult for diet to be changed for one individual, So the question is, can we change lifestyles of families so that the affected individual can change his or her lifestyle? So that's a question which we posed through this cluster randomized trial, which we did in the state of Kerala, where we recruited 368 families with 825 participants in the intervention group and 382 families with 846 participants in the usual care group. The intervention comprised of a comprehensive package of interventions facilitated by non-physician health workers that included screening for cardiovascular risk factors, structured lifestyle interventions, linkage to a primary healthcare facility for individuals with established chronic disease risk factors, and active follow-up or adherence. So in terms of outcomes, we said our primary outcome would be in if people achieved any three of the four, that is the blood pressure less than 140/90, fasting blood sugar less than 100, LDL cholesterol less than 100, and abstinence from tobacco use. If any three of these four were achieved, we thought our primary outcome would be achieved. When we compared the control group, and that is the usual care group, and the intervention group, we found a huge difference. It was almost double the difference. The odds ratio was 2.2. That means nearly 2.2 times number of people in the intervention group had better control, suggesting that a family-based intervention would be extremely useful as compared to an individual-based intervention. Second thing that we can do is, there's a lot of evidence that is coming up, is whether fixed dose combination can improve compliance in people. Because this was originally proposed by Walden Laws way back in 2002, and there have been several attempts to introduce polypill because it provides comprehensive risk factor control, it has a population-wide reach, and it has high efficacy. And the no screening or monitoring is really required, and it's quite cost-effective. So you really do not actually have to measure all the risk factors, but just give people with a polypill. Now, sufficient evidence had not been generated till a few years back. Now we have substantial evidence over the last 3-4 years that polypill actually decreases mortality, decreases future myocardial infarction, decreases stroke almost to the tune of 40 to 50%. It's as powerful as that because it's a very simple mechanism. You just give it. It's like the DOTS therapy in tuberculosis, where a supervised treatment is given to tuberculosis patient and we have a better outcome. Similar to that, we just simplify treatment and give it to patients and it improves outcomes. But there are several barriers to polypill because a lot of doctors fear their autonomy is being compromised. Patients do not accept this. There's an entrenched philosophy that we need to manage risk factors first. We need to step up the dosage by giving single drugs. So all these philosophy and the thinking will have to change. The health system is not ready. Financial feasibility needs to be evaluated. We don't know whether it would ensure equity. How many polypills? Because there are different conditions like heart failure may require a separate polypill. People with bronchial asthma may require a separate polypill. So there are multiple polypills that may be required. And it has not got into the essential medicine list. And the question is, how do we get it into universal health coverage framework? So that is as regard to improving the compliance. The last thing which I want to talk about is how do we improve quality of care? And for this, there are several mechanisms that are available and which we have evaluated through multiple trials and multiple studies. By integrating care, by using electronic decision support system, which actually advises and provides a personalized management plan for the patients, quality improvement program, cardiac rehabilitation, team-based care, and several management principles. And so we evaluated this at multiple levels of care, at the level of tertiary care, at a community level, primary care, and we have scaled it up across the state, and now we are evaluating at a national level. In addition, we are trying to improve access to patients through a telehealth program, where we have created an interoperable platform of telemedicine that embeds electronic health records, point of care diagnostics, electronic clinical decision support system, and numerous state-of-the-art digital health technologies. So these are several technologies that have been incorporated into the telemedicine program, and we are piloting it in the city of Chennai in South India, where we are providing designated telemedicine telemedicine through designated telemedicine centers, We are also providing on-foot telemedicine assistance, and we are working on providing telemedicine assistance through for remote areas. So this is how the dashboard looks like, where you can get general physical findings, which are presented by the community health worker. We have template-based history, where a trained health worker takes a we have vitals that are provided with trends, lab results with trends. We have AI-enabled BCG, which provides we have an electronic clinical decision support, which provides a personalized management plan, a e-prescription, and a markup for follow-up visit, and markup for referrals. In addition, a doctor sitting remotely can auscultate the patient thousands of kilometers away, because we have a noise cancelling stethoscope and we can follow up these patients. In fact, we evaluated this over a 2-year period, and we found that there is a substantial benefit in terms of cost. There's a huge cost saving to the patient, and we can treat quite a few elderly people and identify new people with new diagnosis of diabetes and hypertension. As you can see, amongst these 23,000 people, more than 2,600 are newly detected hypertension, newly detected diabetes, and over 5,000 patients with non-communicable diseases. And the satisfaction level amongst the patients who are using this telemedicine system are pretty high. Finally, I think we need to move beyond clinical trials and our observational studies, look at new methods such as qualitative research, adaptive designs and demonstration projects. We need to look at some advances in statistical analysis, and we need to look at new methods of talking to our patients, talking to our communities, and design interventions in collaboration with the communities. So we really need to reimagine the health system. So if you have to address CVD anywhere, I'm sorry about India here, CVD anywhere, we need to look at research from multiple angles. We continue to do biomedical and epidemiological research to obtain that scientific credibility for the interventions that we plan. But we also need to look at and see whether it's financially feasible, for which we require health economics research. We need to look at operational stability, and so for that we require health systems research. And we need to see if the community is ready and receptive to the intervention that we do, and for that we require social sciences research. So for all these, we need multidisciplinarity, disruptive innovations, and attention to policy and upstream determinants. So let me end my talk with these 2 quotes. One by Toni Morrison, who's an African-American author, who said, if you don't create the future, the present extends itself, and we don't want to do that. And secondly, my favorite poet, Robert Frost, who said that 2 roads diverge in a wood, and I took the one less traveled by. So we need to innovate, we need to think out of the box, and we need to think differently if we have to combat cardiovascular disease in the population. So thank you very much for having me here, and it's a great pleasure to be back here again.
Thank you, Dr. It was very nice talk.
Thank you.
It is my pleasure now to announce Dr. Arshad Tayumi. He doesn't really need an announcement because he's on the beginning with our meetings, and I'm looking forward.
Thank you.
Thank you.
Can you hear me?
Can you hear me?
Yes, we can.
Yes.
There is an echo.
There is an echo.
Okay, it's good.
Okay, it's good.
Can you see my
Can
slide?
you see my slide?
Yes.
I would need the controls, if I may, or I can load mine.
So actually your talk is visible.
Okay, but
very good.
Thank you very much. Again, I'd like to thank the sponsors for the invitation. It's wonderful to join this meeting again, having done so for the last couple of times as well. And it's always a great pleasure. And of course, after Dr. Prabhakaran's talk, this is a very hard act to follow. That was amazing. And so I'm going to talk to you about HDL, and you might wonder, is there anything to be said about HDL anymore? So I'm going to show you some recent data sets that have become available as larger and larger groups of individuals have been studied to see whether or not high HDL is actually good for you, which we have assumed for a number of years that it is. So just to remind you, I'm not sure you can see my pointer, but HDL is the high density lipoprotein, and you see it on the scale. Size-wise, the size of this lipoprotein is smallest, and we have this bunch of different lipoproteins with different density and different sizes. So size increases, density gets less. So the least dense would be chylomicron particles. And if you look at the HDL particle, just to remind you, it has multiple components, which includes lipids, lipoproteins, and proteins that you see there. One of the most important protein that we see is ApoA1. And in this slide, you see what we have all learned. I mean, this has been available, this data for probably 50 plus years. This is a meta-analysis of 68 studies with more than 300,000 individuals, and is showing us what happens to mortality rates as HDL level gets less. The yellow are unadjusted data sets, and blue is adjusted for all of the risk factors. And as you can see, with lowering of HDL, there is increasing risk, which we have understood. And the mantra has been that the higher the HDL, the safer it is. And it is something that we seek to have in our patients. This is a complex slide, so I won't go through it just for the sake of time, but just to show you that one of the biological functions that makes us think, at least mechanistically, as to why HDL is a better particle to have large quantities of, is because it's involved in reverse cholesterol transport. Basically, HDL can take oxidized LDL out of the cell and transport to the liver, so-called reverse cholesterol transport, thereby reducing the atherogenic lipids. And that if you have less of HDL, then presumably you will have less of this reverse cholesterol transport. And in addition to that, other than the reverse cholesterol transport, there are other endowments that HDL has that are thought to be protective as well from the atherosclerosis point of view. And these include its anti-inflammatory, antioxidant, and anticoagulant effects that have also been shown to be present when levels of HDL are higher. So the next question we can ask is, well, does raising HDL pharmacologically lead to reduction in cardiovascular risk? And as you know, there have been multiple trials over the last 3 decades, I suppose, or more, which have looked at agents such as niacin, which increases HDL fibrates, and also CETP inhibitors, which increase HDL levels by almost doubling them. So those are the more profound increases. And so I'm just going to go through some of these meta-analyses that have been looked at. So this is, for example, looking at niacin's effects in when it's been given in combination with people who have been on background statin therapy, and essentially showing that there is no effect of niacin addition and the increase in HDL that it produces on cardiovascular events. Similarly, no effect of fibrates on a background of statins in terms of reduction in cardiovascular events. And similarly, despite almost doubling of HDL levels with CETP inhibitors like dalcetrapib, anacetrapib, torcetrapib, and so on, all of these trials turned out to be negative, and some of them actually led to increased events. So pharmacologically increasing HDL by 3 different mechanisms was not associated with reduction in risk. But just to remind ourselves that if there is no background statin therapy, the earlier trials that were done with niacin and with fibrates showed protection. So people who cannot take statins alone may still have a role for these drugs, but not when they are already on statins. And the other way of looking to see whether something that we consider as a risk factor, which is how HDL is now considered, it's part of our equations like the pooled cohort equation, etc. It's considered as a risk factor, is to look at natural experiments, the Mendelian randomization studies that allow us to do that, which is where we can ask the question as to whether if you were naturally endowed with high HDL or low HDL because of the polymorphisms or genetic variations that you're born with, then does that also reduce risk? So for example, this particular allele, that is written here, LIPG 396, is present in 2.6% of the population. It significantly increases HDL level by about 5 milligrams per deciliter. And you would expect with that kind of increase, there would be a 30% reduction in cardiovascular events. But actually, when you look at this population who has this allele, there is no reduction in cardiovascular events. So in other words, if genetically you are endowed with higher HDL, you are still not protected. In contrast, if you look at LDL polymorphisms that leads to, say, homozygous hypercholesterolemia and so on, then those are actually associated with twofold increase, those people who have those polymorphisms in risk, suggesting that LDL is truly a risk factor and HDL is not. That it doesn't mean that it's not a biomarker of risk, but it may not be actually contributing to it as a risk factor. So then the question is very high HDL a marker of risk in the general population? So here we are looking at data that was recently analyzed by our group, over 400,000 individuals who enrolled in the UK Biobank. So these are individuals without any history of coronary artery disease who were enrolled, both men and women. And I'm going to concentrate on the men and women separately just to make some points. Overall, around 7% of the population has HDL levels above 80. But more of those are women. 11% of women have levels that high and 2% of men. So we are looking at the edge of the curve of HDL. Who are these people who have very high HDL levels where they tend to be older? They are more likely to be female, like I just showed. They have lower BMI, lower triglyceride levels, lower prevalence of diabetes and hypertension, higher cholesterol levels, and greater alcohol consumption. So they are somewhat different than the rest of the population. In fact, they have lower overall risk factors for cardiovascular disease, but are distinguished by the fact that they do have total cholesterol levels, which are also higher because that's composed of HDL as well, and also have higher alcohol consumption. And then if you look at mortality unadjusted in this population, this is shown here. So what you're looking at are hazard ratios with the baseline is this group between 40 and 60, which we consider as the sort of average. That's where most of the population is. Once again, if we look at women and men separately, women actually tended to have lower risk as the HDL cholesterol went up. Was higher, 60 to 80, even the 80 plus group. But men, you can notice that there is a twofold increase in risk if the HDL level was high. Similar extent of increased risk as you see in people with very low HDL levels. So there is indeed a U-shaped relationship, more profound in men than it is in women. And this is just showing you Kaplan-Meier curves in women, showing the low HDL group here, very high risk, high HDL group, not high risk, but in men, both of these groups are at equally high risk of future cardiovascular events. Then if we adjust them for background risk factor profiles, then once again, compared to this 40 to 60 group, in women, there is really no protection compared to this group by having extremely high HDL levels. But in men, once again, there is a U-shaped relationship such that there is a 1.79-fold increased risk in the very high HDL group, just like it is in the very low HDL group in men. So here you can, if you remember nothing else, you can remember this U-shaped relationship, which actually is present in women as well as in men. But in women, the high risk appears at HDL levels above 100. Maybe about 5% of women are up here. And then in men, it's above 80 and above, where about 2 to 3% of men are out there. So not a large population, but if you consider that the whole world has billions of people, this is actually 2 to 5% of men and women is a pretty substantial population to whom up until now we have been saying, oh, your HDL is very high. We use it as a ratio with LDL and say you will never get disease because you are at extremely low risk because your protective lipoprotein is so high. But it turns out that being at that very high level is actually not protective. So we've looked at the heterogeneity between men and women in this data, but really whether you were diabetic or not, it didn't matter. Whether you were drinking or not, it seemed to matter. So this high HDL and high risk appeared to be much more profound in people who admitted to drinking more than those who were non-frequent drinkers. And then we looked at the genetic background to see whether this was because of some, genetic reasons which produces these very high HDL levels. And we looked at the HDL polygenic risk score. There are 142 common polymorphisms that have been described. And for each standard deviation in this polygenic risk score, the HDL level goes up by about 3.5 milligrams, but it made absolutely no difference. So at least we can say that these common polymorphisms are not contributing to this increased risk that we see in people with very high HDL levels. Now, of course, there may be some very specific rare polymorphisms that may still be responsible. And this data set, which was from the UK Biobank, largely Caucasian population, was also reproduced in the Copenhagen population studies. You can see similar U-shaped relationships in men and women there as well. So in summarizing this part of this presentation, we can say that in the general population without pre-existing coronary artery disease enrolled in the UK Biobank, compared to those who had HDL levels 40 to 60, men with higher levels, 60 to 80, have really no advantage. And those who have very high HDL levels, which is about 2% of men, who have levels greater than 80, they're actually at almost twofold increased risk, similar to those who have extremely low HDL levels. In women, this increased risk is seen at levels above 100 mg per dl. The provisos of this data sets is that it's largely the white population. We need to know what the ethnic differences, and we begin to want to consider whether we should revise the pool cohort equation the way it's used, where it gives you extra brownie points for having high HDL levels. So then what about patients who already have coronary artery disease? Once again, this is just showing you the population, the UK Biobank, who had pre-existing coronary artery disease. And we see how, once again, similar results. People, both in men and women, those who had high HDL levels, they had higher risk compared to those who had average HDL levels. So both the very low levels, very high levels, both ends of the curves had high risk. Once again, U-shaped curve for all-cause death, U-shaped curve for cardiovascular death. So that at very high HDL levels, meaning levels above 80, in patients even with known cardiovascular disease or coronary heart disease, there was doubling of mortality risk even after full adjustment. Once again, adjusting for HDL genotype did not impact on this relationship. And that in the subgroup analysis in the Emory Biobank study, where we re-examined this relationship, individuals who were African Americans, Blacks, and those who had diabetics had actually a more profound effect, more higher risk in people who had high HDL levels. So what are the possible explanations for this increased mortality that's associated with very high HDL levels? From the Danish trial that I showed you, and there's another Canadian study that has looked at this, very high HDL individuals may have rare genetic variants that I mentioned earlier that may be responsible for other reasons why they have high mortality. HDL particles in these patients are altered and do not possess antioxidant and anti-inflammatory and reverse cholesterol transport properties that are present for HDL that is otherwise normal in people. And then there is this confounding effect of alcohol intake that may be contributing to this, and that the increased risk is really because these people have higher alcohol intake. Although in all of these investigations, they were adjusted for alcohol intake, and these findings were independent of that. Here's a relationship that's showing you how closely and linearly the levels of HDL are related to increasing alcohol consumption. So the next question is it better to look at ApoA1? Because HDL is complicated. ApoA1 is thought to be the protein that actually has drives some of these effects of the positive effects that we are discussing that are attributed to HDL. So in the UK Biobank, again, we looked at ApoA1 levels, independent of HDL levels, and divided into deciles. And basically what it shows is that there's a very close relationship between ApoA1 levels and HDL levels. So they're almost linearly related, not very different from each other. Once again, women had higher ApoA1 levels, just they have higher HDL levels compared to men. So these are the Gaussian curves that you see. But when we looked at these deciles of ApoA1, once again, U-shaped relationships, so very high ApoA1 levels, both in men and in women, the cutoffs being a little lower for men and a little higher for women, but they're both associated with increased risk. So in the highest decile, the risk was between 27% for all-cause death, 44% higher for cardiovascular death in men, and also 23% higher mortality in women. So just a reminder then, whether you're looking at HDL or its main particle, ApoA1, there is this U-shaped relationship, both in men and women, cutoffs being a little higher in women than it is in men. What are the possible other reasons that may be causing this increased risk, not just of cardiovascular mortality, but also non-cardiovascular mortality? So there is some data to suggest that these individuals who have very high HDL levels may have increased risk of cancer, kidney disease, lung disease, autoimmune diseases, and so on. So they have predilection for other things that really need to be further studied. So just as a final reminder, then, low HDL cholesterol is associated with increased risk of ASCVD. We shouldn't forget that. This is what we have been using, even in our formula that we use. And these have been confirmed in numerous studies, that the genetic evidence from candidate gene studies that have shown inverse correlation between HDL cholesterol and concentration risk of ASCD, all of these Mendelian randomization studies are telling us that there is no causality there is no sort of risk factor relationship between HDL levels and cardiovascular disease risk or coronary artery disease risk. And that HDL cholesterol increasing trials have so far not been shown to be able to reduce risk in ASCVD individuals in general, especially in the background of statins. And despite lack of support for the causal role of HDL cholesterol concentration, can still be used as a biomarker of ASCVD risk prediction, and lifestyle intervention that lead to like exercise and cessation of smoking that are associated with the reduction in risk should be considered. So thank you very much for your attention.
Thank you, Dr. Kayumi. Organizers, are we now going to show a presentation by Dr. Amit Shah?
For 5 minutes, 1 minute. Kuyumi, please stop share. Kuyumi, please stop share.
I am trying.
My name is Amit Shah.
I don't know how to do this. Let me.
Evo se pojavio na ovom tom laptopu.
My name is Amit Shah, and I'm an assistant professor in the Department of Epidemiology, as well as in the Division of Cardiology at Emory University. And I'm the Director of Preventive Cardiology at the Atlanta VA Healthcare System. And today I'm going to talk to you about psychosocial stress and cardiovascular disease. Zooming out, thinking of it in a big picture, stress is a multi-dimensional construct. And the American Heart Association has defined stress in many different ways, including traits such as anxiety, anger, chronic stress, pessimism, depression. But on the flip side, we also have elements related to wellness, such as psychological well-being, mindfulness, gratitude, optimism, and sense of purpose. Now, in their latest article outlining Life's Essential 8, in which we discussed risk factors and behaviors related to cardiovascular disease, they described that stress is a fundamental component of behaviors and of cardiovascular risk, broadly speaking. But needless to say, a really clear way to measure stress remains elusive, as it is really difficult to measure. We know that stress is a big deal. Chronic stress leads to something called allostatic load and weathering. Weathering is defined as chronic exposure to socioeconomic disadvantage, marginalization, and discrimination that can lead to early health deterioration. When we think of weathering, we think of things like racism, poverty, bias, alienation, structured inequality, unfair access, prejudice. So a lot of psychological stress can be considered to be rooted in social determinants and societal factors. This can lead to chronic changes in health over time and weathering, ultimately leading to increased risk of cardiovascular disease as well as overall mortality. Not only is stress multidimensional in how we define stress, but it is also multidimensional in what it does to the body. Some dimensions include autonomic dysfunction, such as decreased heart rate variability, neuroendocrine activation, such as including increased cortisol and catecholamines, hemodynamic changes, higher blood pressure, higher heart rate, coagulation activation, including platelet activation, increased viscosity, and immune activation, including increased cytokine levels, for example. This can lead to cardiac electrical instability and arrhythmias such as atrial fibrillation, myocardial ischemia, and subsequent events like chest pain or angina, atherosclerotic plaques, and thrombus formation, which can lead to myocardial infarction. The clinical manifestations include ventricular tachycardia, ventricular fibrillation, which can lead to sudden cardiac death, atrial fibrillation, myocardial infarction, acute coronary syndrome, and stroke. As we dive deeper into some of the electrical connections between the heart and the brain, where we can think of being one of the focal areas of stress processing, there are several regions of the brain that we have identified using neuroimaging and animal studies that have direct relationships with the heart, and these relationships are mediated by things like the HPA axis, the cardiac autonomic, the central autonomic network, the brainstem, and also behaviors that the brain can direct, such as movement, like reduced physical activity, and sleep disruption that can be a consequence of stress. So when we think about the multidimensional aspects of stress, we can also map out the anatomy of stress into neurohormonal pathways, autonomic pathways, and behavioral pathways. And an important but very difficult to measure pathway includes the intrathoracic extracardiac ganglia that have a bidirectional relationship with the autonomic circuits. The heart itself has also the ability to react to stress, both directly and indirectly. This is something that is less often discussed, but the heart is very active from not only from a hemodynamic perspective as we think about blood circulation, perfusion, but also from the perspective of neurological regulation as we think about the baroreceptors, carotid body chemoreceptors, as well as the intrinsic nervous system of the heart. And events such as myocardial infarction will actually cause remodeling in this area. Peripheral artery disease can cause disruption in the baroreceptors, for example, also causing them to become dysfunctional. So there is a bidirectional pathway between the heart and the brain that underlies stress. One of the key measures of stress is depression. It is probably one of the most well-studied exposure variables of stress that is a known risk factor for cardiovascular disease. Depression is very complex and very common. It affects 1 in 6 adults at some point in their life, and it affects women more than men, perhaps double the number of women compared to men. Not only does it include sad feelings, a depressed mood, but also somatic symptoms such as changes in appetite, sleep disturbance, changes in physical activity, feelings of worthlessness or guilt, difficulty concentration, and ultimately thoughts of death or suicide. The evidence shows that depression, even in adjusted models, are associated with about a 2-fold increase in the risk of cardiovascular outcomes. This is roughly equivalent to other traditional risk factors such as smoking and diabetes. Another very common condition that is a manifestation of chronic stress is post-traumatic stress disorder, or PTSD. Typically, this is triggered after witnessing a traumatic event. We see a lot of people who are soldiers going to war and witnessing a lot of trauma on the battlefield, for example, will have PTSD. But even in everyday life, there is a lot of trauma that people are exposed to across the world. In the United States, this affects about 11% of the population at some point in their lives, women more so than men, as with depression. So it's not as common as depression, but still very prevalent. Post-traumatic stress disorder is considered something that occurs when someone has intrusive thoughts of trauma. They are frequently reminded of trauma, they're triggered by it. They have a lot of negative thoughts and feelings, which is an overlap with depression. And they are very arousable, very reactive, very irritable, for example. Unfortunately, post-traumatic stress disorder is perhaps even a stronger risk factor for heart disease than depression itself. In a study that we performed with twins, where we compared a brother who developed post-traumatic stress disorder, who was a veteran, with his brother who did not develop post-traumatic stress disorder, we found over a 2-fold increased risk of coronary heart disease events. These are clinical coronary heart disease events about 10 years after their diagnosis of post-traumatic stress disorder. This included myocardial infarction, any kind of hospitalization for coronary heart disease, and revascularization, which is a reaction to progressive atherosclerosis that leads to clinical symptoms and a treatment. Not only does stress associate with clinical events such as myocardial infarction, but also events that occur at home, namely sudden cardiac death, which oftentimes presents outside of the hospital setting. And it is really hard to measure because we do not have an opportunity to speak with someone and understand what the trigger was for sudden cardiac death in the community. But sometimes large-scale events can help to inform us on what the risk of acute stress is for sudden cardiac death. On this slide, we have a figure from, or figures from a New England Journal article, a very famous article about an earthquake, the Northridge earthquake that happened in Los Angeles County in 1994. And the number of deaths skyrocketed during the earthquake that were cardiovascular disease related based on the autopsies that were done. These are data from the coroner in Los Angeles County. And you can see that compared to previous years, there was no spike. These were non-traumatic deaths, such that they died suddenly, and it wasn't due to the trauma of the earthquake itself. It was in the middle of the night. This was thought to be due to acute psychological stress. What we also can measure in real time is the effect of acute stress on blood flow. These are pictures that are from the heart and using SPECT radionuclide imaging. And they are captured during a mental stress protocol in which we ask the participant to give a speech about a loved one being abused in a nursing home. And we inject a radionuclide, technetium radionuclide, during that speech. And then we do imaging after the fact, after it traps in the myocardium. And we compare it to a control period in which they are resting. And the dark here on the right-hand side is an example of mental stress-induced myocardial ischemia, because the dark part is the reduction, represents the reduction in blood flow that occurs during acute mental stress challenge. So this is something that we found occurs in 15 to 30% of people with coronary artery disease. Ischemia being defined as insufficient blood flow, which we are observing here in this picture in the upper right-hand corner, that's occurring during mental stress. It's not necessarily going to happen during physical stress. So many of us are familiar with physical stress ischemia or pharmacological ischemia. Some people will have mental stress-induced myocardial ischemia, but not physical ischemia. Many people will have both, but not everyone with physical ischemia will have mental stress ischemia. It's thought to be due to a disproportionate vasoconstrictor response to acute psychological stress, and likely brain-based pathways are implicated, as well as endothelial dysfunction in the coronary arteries. It is thought to be more common and more toxic in women compared to men, and it is associated with an extremely high risk of myocardial infarction and death. We had a recent paper in JAMA that showed nearly a threefold relationship with cardiovascular outcomes in those with mental stress ischemia. This is presented here on this slide. We can see that people who, in a cohort of participants with coronary artery disease, we found that 96 of them, out of approximately 900 people, 96 of them, about 1 in 10, had both mental stress and conventional stress ischemia. 49 had mental stress ischemia alone. 185 had conventional stress ischemia alone. This is pharmacological or exercise. And 569 had no evidence of any ischemia at all. They were the reference group. And what we found was that the people who had both types of ischemia, mental and conventional stress, they had the highest hazard ratio for outcomes, adverse outcomes. This includes myocardial infarction and death in a follow-up of 6 years. This was less so with mental stress ischemia alone, conventional stress ischemia alone, and then no ischemia alone. Note that clinically, we usually only do conventional stress ischemia, but note how if we conduct both mental stress and conventional ischemia, we are able to obtain a much better idea of someone's risk level, because the mental stress ischemia component is much more important than conventional stress alone, or it provides a lot of context in understanding someone's risk further. Now, taking a step back and looking at other studies that have looked at stress in its many dimensions, we can see here that there have been a lot of studies published in the literature that look at negative psychological factors and various different cardiovascular disease endpoints. And the hazard ratios, the odds ratios, the risk ratios, these are all in about like 1.5 range for these various outcomes. And there are some that stand out, such as coronary artery spasm and anxiety and pessimism and CHD mortality, although this is the highest versus lowest quartile. Needless to say, a lot of this points in the same direction. Notice there were relatively few studies on PTSD in this review. On the other hand, studies on positive psychological factors, which is not 100% overlapping with negative factors. They're not necessarily just two different sides of the same coin. Studies show that it is worth measuring both independently. But in general, positive psychological factors are considered protective. This includes optimism, sense of purpose, happiness. And then the other thing that we found was that mindfulness has a protective ratio for good cardiovascular health, non-smoking, normal body mass index, fasting glucose, and physical activity, high physical activity. And emotional vitality is important, as well as overall psychological well-being and cardiovascular mortality. So measuring stress and wellness together can probably yield the best measures of how someone's doing. One of our cardiology fellows, now faculty, Kasra Mosami, did some really interesting work looking at stress activation and cardiac outcomes in the brain. We had a study of over 150 participants that underwent stress testing using arithmetic and speech stress while they were laying in the brain scanner, using O15 water imaging of the brain. And we were able to examine dynamic changes with stress that occurred in their relationship with cardiac outcomes. And we found that an area called the rostromedial prefrontal cortex, located in the very, very kind of front of the brain, was associated with adverse cardiovascular outcomes, such that those who had a higher activation in the rostromedial prefrontal cortex with stress had significantly worse outcomes, the hazard ratio of over 3 compared to those with low stress-induced activation. And what we found was that this relationship was partially mediated by inflammation and by autonomic dysfunction, with inflammation being measured by interleukin-6 and autonomic dysfunction being measured by high-frequency heart rate variability, which is a measure of vagal activity. And those who had high reactivity in the rostromedial prefrontal cortex had more vagal withdrawal with stress and more inflammation with stress. And that this partially, but did not completely explain the increased risk of cardiovascular events. We also found that many regions in the brain when activated with stress, associated with angina, as reported by the participants, using a question that asked about frequency of angina or chest pain within the last 30 days. And we looked not only at brain activation in one of the key areas, the inferior frontal cortex, but we also examined their Beck Depression Inventory score, their PCL score, post-traumatic stress disorder checklist score, mental stress-induced myocardial ischemia, and then other demographic factors and cardiac risk factors. Note that in this figure, which looks at the relative importance of these different parameters, most of these parameters are related to stress or sociodemographic factors. None of the ones that we currently focus on, traditional risk factors, conventional ischemia, these were not correlated with angina. It was only the psychosocial risk factors and in particular the brain activation that was associated with angina, making a very strong statement about the etiology of chest pain and questioning how do we best deal with chest pain. So as you think about the stress cascade, we start with psychological stress and its multidimensional sort of presentation with the genetics, the trauma exposures, the life situation of people and their interpersonal conflicts, their everyday stressors, including things like work stress. This leading to changes in behaviors, but also the behaviors may also yield a reaction and make stress worse. For example, as someone, for example, makes poor food choices due to stress, which we call toxic hunger, for example, substances, sleep disturbance, and then ultimately both of these can contribute to cardiovascular disease risk. And having cardiovascular disease can also be stressful and can lead to behavior changes. Now, I'd like to spend some time talking about the different interventions. So we talked a lot about stress. Let's say that we are all sold that stress is an important part of cardiovascular disease assessment and interventions. What do we do about it? This is always the big question because we are trying to get to the point where we can save lives with this. We can think about different interventions in three categories here. One is brain-focused interventions, autonomic interventions, and pharmacological. The brain interventions I'm categorizing as things like cognitive behavioral therapy and transcendental meditation, where we have studies that examine the impact on the brain specifically. And a lot of the mechanisms of these interventions likely start in the brain and then have downstream effects on the heart. The autonomic nervous system is more distributed in the brain and the body together. I'm thinking about the different reflexes in the body, the cardiac, intrinsic cardiac nervous system. There are treatments such as vagal nerve stimulation, heart rate variability biofeedback that are important. Exercise is known to be an intervention that improves autonomic activity. Yoga is a mind-body one, but even just aerobic exercise has really important effects. A lot of this is also seen using brain imaging. And then cardiac rehabilitation is an underutilized but extremely important holistic intervention that incorporates exercise, stress reduction, and nutrition. Pharmacological therapies are usually easier to implement, but do not have necessarily the holistic benefits that some of these other interventions do. So it's a bit of a give and take. Drugs like propranolol, which are have a dual purpose for hypertension, also can help with at least acute anxiety. Someone who has panic attacks, for example, may particularly benefit from propranolol. And then antidepressants are oftentimes one of the first things that we think about, at least for depression, but also has use in other conditions like chronic pain, because they are stimulants as well, at least on the brain, and have other effects on the vasculature, for example. It's not really clear on the safety and the benefits of antidepressants. SSRIs are ones that have at least a little bit more evidence, at least of not doing harm. Some studies have shown that as part of a larger stress intervention that they may be helpful, but not really conclusively. Other medicines such as tricyclic antidepressants, which inhibit the reuptake of norepinephrine, maybe even are more stimulating, and some of those unfortunately have been associated with increased cardiovascular risk as a result. One thing to consider with antidepressants as well is the starting period and then the transitioning off of antidepressants. Suddenly stopping antidepressants may also be considered risky based on some studies. In conclusion, what I'd like to say is psychological and social factors are fundamental to the pathogenesis of cardiovascular disease. I'd like to highlight both physiological pathways and behavioral pathways. But for treatments, most of the evidence is in favor of behavioral interventions, more so than pharmacological interventions. But challenges remain in terms of implementing it. In the United States, these are not, for example, reimbursed, as well as some of the other things. And so the healthcare system needs to be modified to make more space for these mind-body interventions. Thank you for your time, and it was an honor speaking with you.
Thank you to Amit for submitting this very nice work. And even it was recorded, it was real the pleasure to see that. And I do expect that next one is Dr. Anshul Saxena, who will talk about hospital outcomes among COVID-19 hospitalizations using California State Inpatient Database. So Anshul, you are muted. So once when they give you a control, please unmute yourself and
Okay. Should I share my screen?
yeah.
Okay. Okay. So I hope everyone can see my screen. Very good afternoon from Miami. My name is Anshul Saxena. I work for Baptist Health South Florida as a manager of biostatistics and predictive analytics. My presentation is about analyzing a national database, and we were interested in finding associations for adverse healthcare outcomes, especially among inpatient population who had COVID-19, and among that, what were the differences between the groups who had myocarditis versus those who did not. So first, acknowledgement to my co-authors, and I do not have any relevant disclosures. So background, as we already know, COVID-19 has caused significant morbidity and mortality among those who were affected. And though initially described in some case reports, it is now established that some patients do develop myocarditis as one of the complications, but the large-scale studies are still, or data from large-scale studies are pending. And some studies have stressed that the importance of myocarditis as a prognostic factor for predicting morbidity as well as mortality among these patients are important, and that's why one of our research questions for this study was to find this association. So as stated, objective was study is to examine the association between myocarditis among COVID-19 hospitalizations and in-hospital mortality and other adverse hospital outcomes using a large database. So what did we use? So we utilized California State Inpatient data from 2020 that had COVID-19 cases, and the state inpatient database include both clinical as well as non-clinical information, primarily about from the domains of diagnosis, procedures, discharge disposition or status, demographic characteristic, their insurance or payer information, then charges and length of stay. So our inclusion criteria was very broad. So we included all adult patients who had COVID-19 identified through ICD-10 codes, and they were grouped into two groups, one with myocarditis and one without myocarditis. And our primary outcome was in-hospital mortality, and secondary outcomes were cardiac arrest, cardiogenic shock, mechanical ventilation, and acute respiratory distress syndrome. And to compare apple to apples, we utilize propensity score matching to account for potential confounders or differences in demographics and some clinical variables among or between these two groups. And we perform survival analysis on unmatched as well as matched data set using Kaplan-Meier estimates to compare differences in 30-day mortality between these two groups. And in addition to that, we also utilize multivariate conditional logistic regression, and we use that to find the association between myocarditis and cardiac arrest, cardiogenic shock, use of any mechanical ventilation, and acute respiratory distress syndrome. So the secondary outcomes. Here are the demographic, some of the demographic characteristics. So as we can see, we have two groups as columns. So those with myocarditis are few, only 578 cases. And in terms of differences in demographics, only among the variable of sex, we see some differences. As we can see, patients who had myocarditis were majority males, so 61% compared to 54% among those who did not have myocarditis. Among race, we see the distribution is almost similar, so 25% white, then black, and majority of them in both groups, which is 53% and 51%, are Hispanic, and rest were Hispanic, Asian or Pacific Islanders and other races. Insurance wise, about 42 to 43% were Medicare patients, and then followed by Medicaid 30% and 28.7%, followed by private insurance, so which were about 22% in both groups, and uninsured were about 2% in both groups. Age distribution wise as well, we can see that majority, not majority, but around 44 to 45% cases were at least 65 years or older, and after that the second biggest group was 45 to 64 years old, and then 18 to 44-year-old. So this is a graph showing standardized mean differences, which is basically showing the differences before and after propensity score matching. So the pink color is for before propensity score matching. So we can see there in the patient mix there is a lot of variability, and especially in terms of past medical history of congestive heart failure, any coagulation disorders, liver disease, or history of prior MI. Sex, so again male and females in both groups were also different, but if we see prior cabbage, hyperlipidemia, obesity, hypertension, prior PCI, those variables, especially even diabetes mellitus and tobacco use, those were not that far. But after propensity score matching, most of these, with some exception of like prior MI, are the differences near zero. And as we can see, the percent wise, where the green color is patients with myocarditis, and the blue color is patients without myocarditis, we can see a huge difference in hospital mortality and mechanical ventilation. So in hospital mortality was about 30% versus 15% among those without myocarditis, and mechanical ventilation was about 40% compared to less than 15% among those without myocarditis. Other variables such as cardiac arrest, cardiogenic shock, and ARDS also had significant differences in proportions. Moving on to the Kaplan-Meier survival analysis. On the left graph, we can see the unmatched hospitalization. Although we see on the x-axis there is a huge difference in length of stay. So among patients who do not have any myocarditis, some patients did spend longer time in the hospital, but at least the survival probability was initially higher as compared to myocarditis, and this difference was also significant. And in the matched cohort, matched by propensity score matching, we see that patients with myocarditis, which is the blue line, has lower survival probability as compared to patients who did not have myocarditis. And this difference was also significant. Now moving on to odds ratios for our secondary outcomes. So we can see almost all values are statistically significant, and these odds ratios were calculated using a conditional logistic regression after accounting for age, sex, race, insurance, so all the demographics, then hypertension, diabetes, hyperlipidemia, obesity, atrial fibrillation, coagulation disorders, PVD, liver disease, chronic renal failure, tobacco use, alcohol abuse, so substance abuse, as well as past medical history, also including stroke, CHF, prior MI, and then some history of procedures like CABG or PCI. So after accounting for all these confounding variables or variables that we thought could confound the results, these outcomes or odds ratios were still significant. So first one is cardiac arrest, so odds ratio of 1.9. Cardiogenic shock was very high, 4.1, then mechanical ventilation 3.3, and ARDS almost 2.5. So moving on to conclusion, our study using a large administrative database found that myocarditis was associated with greater rates of in-hospital mortality and adverse hospital outcomes among COVID-19 patients. And hence we suggest that all healthcare providers, physicians should be vigilant for emerging signs of myocarditis and attempt to aggressively manage this condition. And any future prognostic models or methods for estimating mortality and adverse outcomes among COVID-19 patients should include myocarditis as a risk factor for better accuracy. And this article was published in American Journal of Cardiology in November. So if viewers need more detailed information, they are directed to this article. And I think we are doing okay with time. Thank you very much for listening to this presentation. And on screen I have my contact information, so if you have any questions, please do not hesitate to contact me. Thank you so much.
Thank you, Anshul. It was on high professional level as usual. So my pleasure is to announce next speaker, which also belongs to the same group, and that speaker is Muni Rubens.
Can you see my screen? Can you hear me?
Yes, we can hear you and we can see your slide.
Oh, okay. So I am Muni Rubens, and I work as a biostatistician and a clinical researcher at Miami Cancer Institute. First of all, thank you for the organizers for inviting me. And today I'll be talking about association between frailty and unplanned readmission and mortality among hospitalized heart failure patients. So before I start, I want to acknowledge the researchers who were associated with this study, and I don't have any financial or non-financial disclosures. So coming to the background, we all know that heart failure is a major cause of morbidity and mortality, not just here in the US, but globally. In US, there are around 6.5 million people with heart failure above the 20, and nearly 900,000 people are diagnosed every year. And this rate is going to increase, and the projected estimate is that there will be 46% increase by 2035. And that is mostly because of increased elderly population. Now, there are different measures which we can use to measure the quality of hospital treatment among heart failure patients. So some of them are hospital readmission, then in-hospital mortality, then length of stay and complications like cardiac shock or cardiac arrest, etc. And in US, federal government can penalize hospitals with high rates of readmission, 30-day readmission for heart failure patients. Now coming to frailty, frailty is defined as decreased physiological reserves and is commonly seen in elderly population. And that can include unintentional weight loss, then history of fall, loss of vision, dementia, then slow walking, etc. And in this study, we looked at how frailty in traditional risk-adjusted model based on comorbidities could improve predictability of unplanned 30-day readmission and mortality among heart failure patients. So coming to the method, it is a retrospective cross-sectional study, and we used a nationwide readmission database for the years 2010 to 2018. And NRD is the largest readmission data in the United States, and it gets data from 28 states out of 51, and every year reports 18 million hospital discharges, and that represent around 60% of US population. So in this study, we identified hospitalized patients with heart failure, age more than 65 years, and we identified this hospitalization using ICD-10 diagnosis code, that is International Classification of Disease 10 diagnosis code, as a primary diagnosis of heart failure. Then we stratified these hospitalization into those with and without frailty. So for that, we used John Hopkins ACG, that is Adjusted Clinical Group Frailty Defining Diagnosis Indicator, which uses 10 measures to identify frailty. So those include malnutrition, dementia, then loss of vision, decubitus ulcer, urinary retention, loss of weight, then fecal incontinence, lack of social support, difficulty walking, or history of fall. So if any of these 10 measure is present in a patient, that patient will be defined as one having frailty. Then outcomes are, as I described, it's a 30-day unplanned readmission and in-hospital mortality. Now coming to the result, this is a little busy table. So if you look at the yellow and green box, yellow is a frail group, the green is a non-frail group. So this is the comparison of demographic characteristics between people with and without readmission in the frail group, and with and without readmission in the non-frail group. So in the fail group, you can see that almost all demographic and hospital-related characteristics were significantly different, except elective admission and income. In the frail group, all the characteristics were different between those who had readmission and those who didn't have readmission. Now, the most important finding from this study is that among frail group, that is 63,302, 22,000, around 22,000 people had readmission. That is around 35%. Now, if you compare that with non-frail group, it is 168,000 among 756,000. That comes to around 22%. So the comparison of readmission in the frail group is 35 versus non-frail is 22. Now, second important finding is that second last row, death. So in the frail group, death rate is 16.2%, and in the non-frail group, it is around 8.2%, almost double. This is almost same table where we are comparing comorbidities, that is secondary cardiovascular complications like cardiogenic shock, AMI, CAD, cardiac arrest, arrhythmia, and around 14 comorbidities. Then past medical history, that is prior MI, PCI, CABG, and MI is the most common cause of one of the most common cause of heart failure. And procedures like vasopressor use and mechanical ventilation. And if you look at the p-value, you can see that among the frail group and non-frail group, there was significant differences, and these rates, that is these comorbidities and complications were relatively higher in the readmission group. After this, we did binary logistic regression, we did two models initially, one for readmission and one for mortality. And we adjusted for demographic characteristics, then hospital characteristics, and all the clinical features which I described just now. So you can see that the odds for frailty is 1.18, meaning in the frailty group, the readmission rate was 18% higher. Similarly, mortality was 52% higher in the frailty group. After this, we compared models with and without frailty. So initially, we did a regression for mortality, one with frailty and one without frailty. So the mortality, that is the second table. So for mortality, you can see that with frailty, the C statistics, that is concordant statistics, was 0.883, and it reduced to 0.840 when we removed frailty from the model, and that difference was significant. Then if you look at readmission, that is 30-day unplanned readmission, you can see that with the frailty it was 0.621, and it decreased to 0.580 when we removed frailty from the model, and that difference also was significant, showing that including frailty in the regression model was very important. Before I go to the conclusion, there are some limitations to our study. First one is that we used retrospective design, retrospective cross-sectional design. So we cannot assume causality between frailty and readmission or frailty and mortality. So future studies should incorporate prospective case control studies, prospective studies to prove this association. The second is that we used Johns Hopkins frailty defining index for identifying frail people. So this is a binary tool, binary outcome tool, where the tool will tell you whether the patient has frailty or not, doesn't have frailty. So we were not able to stratify people into different degrees of frailty, like not frail, pre-frail, close to frail, or frail. So that was another drawback of our study. Then this is an administrative data, and we used a discharge diagnosis for identifying patients. So there could be misclassification bias due to coding errors. That is another limitation of our study. And finally, we were not able to get lab data, for example, BNP or pro-BNP, like a brain natriuretic peptide for heart failure, or echo imaging studies like echo, where we can find the ejection fraction or left ventricular end diastolic volume or left ventricular wall thickness, or medication data, for example, the drugs used in heart failure like beta blockers or AC inhibitors or diuretics. So that was another drawback. Now coming to the conclusion, we found that frailty is common in patients hospitalized with heart failure, and the prevalence was 8.4%. Remember that this patient group is elderly population, more than 65 years. And the most important finding of our study is that inclusion of frailty in comorbidity-based risk prediction models significantly improved the predictability of outcomes, such as unplanned 30-day readmission and in-hospital mortality. And the finding of our study reiterates the notion that there should be measures to identify and stratify hospitalized heart failure patient into high risk and low risk group based on frailty, and there should be interventions to improve hospital outcomes among frail heart failure patients. Currently, there are no cure for frailty. Only thing we can do is improve the severity of frailty. So one of the things we can do is multi-professional groups where cardiologists can associate themselves with physiatrists, like physical rehabilitation physicians, and improve their physical functioning. That is one of the interventions which can be done in heart failure patients. And this study was published in the Journal of Aging and Health recently, and you are welcome to go and read more about this study. Thank you.
Thank you, Dr. Moni. Very well executed study. It was a pleasure looking into these results. And now for something different and something that I've been waiting for, Peter McGranahan will present something that I do expect will cause some interest among all present listeners. So, Peter, your place.
Okay. Hi, my name is Peter McGranahan. I just want to first thank the organizers of this conference for letting me talk. And today I will be talking about artificial intelligence in cardiac surgery outcome prediction and treatment planning. It's not a comprehensive presentation. It's mainly focused on my work at the Deutsches Herzzentrum der Charité, which is the heart center of the Charité University in Berlin. It's where I did my PhD and my postdoc. And today I'll be talking about our prior work, our current work, and our future work especially in regards to expanding in the US. Quick background, the main objective or the main problem we can say is we would like to address the gap between clinical guidelines and practice or the real world. So if we're talking about clinical guidelines such as the AHA or ESC, this would be kind of the ideal scenarios for each patient's treatment strategy decisions. And then we talk about practice, which is the real world. So there's obviously a gap between the two, and our goal is to close that gap as much as possible using data analytics and technology. And some reasons for this gap could be disparate clinical data. So the data entered by providers into the EMR are not optimized for analysis. They're not meant for analysis. They're mainly meant for just data entry and operational purposes. In addition to that, clinical guideline information is publicly available, but is not structured in a way that can be connected to patient data or for analysis. It's pretty much a textbook or PDFs online that we have our clinical guidelines in. So with that said, we think there is a need for a unified platform that does connect the two, the patient data and the clinical guideline data. So the physicians can have the most relevant data to make the best treatment decisions, or they can conduct research studies or drive value-based care programs, for instance. So the team that I'm part of at the Heart Center is called the Data Science and Machine Intelligence and Cardiovascular Medicine team. It's a team of about 10 of us, and we have several partners. Our most important partners, you could see one of them is the Institute for Imaging Science and Computational Modeling, Cardiovascular Medicine. They are our computer vision experts. We go to them for all of our image data analysis. The Berlin Institute of Health, this one here, they actually have an accelerator program that they can help commercialize our research, so they can take any of our research and bring to market, for instance. The last one, the German Center for Cardiovascular Research, they are pretty much our funding body. They provide us with grants to conduct our big research projects. And I just want to briefly discuss the prior work before I go into the current work. The team I joined, before I joined, they had published 2 papers in The Lancet and Nature Digital Medicine. And the first one in The Lancet, they published a study of a real-time prediction model for postoperative bleeding in the ICU. And the second one was using that model and being able to predict acute kidney injury. And with those 2 papers, they took it to the Berlin Institute of Health and created a company called X-Cardiac. And they took these 2 models and they developed their own app that could be integrated right into the EMR. And that's what you see in the bottom right is the real-time prediction of bleeding. Within, they can predict up to 4 hours. So they have all the ICU beds here, and you can click one ICU bed, for example, and see the risk of bleeding in real time. So this helps providers focus on the high-risk patients more, or if they just come in for their shift, they can see their census and see which patients will need more attention than others based on their risk of either bleeding or acute kidney injury. So with that, the next phase, the next project is called the Virtual Heart Team. So this is the current project that I'm managing, a small team of data scientists. And it all started because they have a heart team, which is a multidisciplinary team of cardiologists and cardiac surgeons who meet quarterly to discuss specific cases and make treatment decisions. And when COVID hit, this team had to go virtual. That complicated things because if you can't meet in person, you can't open up the guidelines, discuss the cases in the EMR. So we had to build a centralized platform that brings in the guideline data and the patient data and makes suggestions for treatment. The title of this project is Machine Intelligence Augmented Environment for an Evidence-Based and Data-Driven Therapeutic Decision-Making. We received funding starting 2 years ago for 1.1 million euros. So there's 2 years left on this grant. And the main objective like I said, was to make automated treatment suggestions for cardiac surgery patients. Our first use case is to make treatment decisions, suggestions for CABG versus PCI. And right now, how we do it is our workflow as a simplified diagram on the right. The provider will submit a patient review submission form that gets loaded into REDCap. We have 4 medical students that then review the patient's medical record and they enter the data into REDCap. So we have about 200 to 300 data elements from pre-op to labs, medications, angiograms, post-op, and outcome data as well. This data gets analyzed and pushed out to a dashboard that can then be used at the heart team meetings. So this is the general workflow for the virtual heart team. We divided the team into 2 sub-teams, you could say. We have those doing the structured data analysis and then the unstructured data analysis. I mainly work in structured data analysis, but how we do that is we take the guideline decision trees. So the one you see on the left is the decision tree for PCI or CABG. And we extract the data from the EMR and we apply this decision tree to that data. So if you see here, if a patient has 3 vessel CAD, if they have a syntax score less than 22, diabetes, then it's recommended they get CABG. So this is what we apply to the data. The most complicated data point, I guess you could say, is syntax score, because the data elements in the syntax score are quite complicated and not able to be automated. So it is a very manual process, but there are several institutions and companies who've tried automating the syntax score, and we are also working on that. For the unstructured data analysis, we have the ICM team analyzing the angiogram data. They have developed a deep learning model that can analyze the DICOM files in the PACS system that hosts the angiogram files, and it can detect the exact vessel and the percent of stenosis. So it's just a screenshot that it can detect here stenosis. It can detect up to 3 vessels, and it also give you the confidence of that detection. And I just want to show you how we integrate that into one unified platform. We show the current situation of every patient, from their general history to their medical and surgical history and lab measurements. And then for the angiogram, we show what is available on the angiogram report. And when you click this link, it'll take you to the angiogram analysis that I showed on the previous slide that shows the percent stenosis. Also, we will show the in the risk assessment module, we have the syntax score and whether it's low or high based on the guidelines being, greater or less than 22. And the 5-year risk of cardiovascular event for PCI or CABG. These risk percentages came from the syntax trial group. We are working on getting this risk prediction based on the cohort available in the institution, but currently our sample is too small. We have about 300 patients, 333 patients, but this is something we are considering. Right now, what we show is the risk based on the syntax trial. then based on that decision tree that I showed you earlier, we give a recommendation of cabbage based on that decision tree of what's in the guidelines and in the patient's data. Obviously, we would like to get more detailed, or we can give more detailed recommendations, such as cabbage on or off pump, but this is on an institution by institution basis. And then, of course, we can show the analysis of what similar patients to this current patient received or followed the clinical guideline. So there's kind of two parallel analysis that we can do. We could see how many patients of this cohort, so let's say CAD patients who actually receive the guideline guided treatment recommendation, and then we can do it prospectively to say this specific patient should get cabbage or PCI. And we provide links to the full guidelines and the individual decision tree that determined what treatment type this patient should get. Now with this, we did incorporate a company called Dr. Data, and we're saying it's a next generation clinical decision support system. There will be three pillars to this company. One would be access to the data that we collect, not only at the Heart Center, but also other institutions that we plan on partnering with. We could also offer the platform, the decision support platform that makes recommendations. Also, we can provide the analytics and data science service. So one of the main reasons we did create this company was we submitted a pitch to America's Seed Fund, and it passed the first step, I guess you could say, and they gave us a 1-year time frame to submit an official proposal, which would be due February of 2024. In order to submit this proposal, you have to have a company already incorporated. And if you are in the STTR, or Small Business Technology Transfer Research, which is what we are in, it's required that you have a partner institution. So that's what we are currently looking for is a partner institution who we can work with on developing a minimal viable product, or MVP. And we would follow the same workflow and use the same or similar models to what we use, but there's also, of course, flexibility in different analyses, such as health equity analyses, clinical guideline adherence, and this can be part of the platform. And the idea is, once we develop the MVP, we will be able to approach other hospitals, collect more data, and offer this access to this data and to the improved platform as we iterate and move along. If all goes well, then there's a phase 2 for the America's Seed Fund. The phase 1, the maximum is $285,000, and phase 2 would be $1 million. And that's what I'm just showing here is the 2-year action plan based on this. So in summary, our main objective is to close that gap between the ideal scenario in the clinical guidelines to make treatment decisions and the real world, so what's happening in practice. And by closing this gap, we can make sure that the patients are receiving the best possible treatment strategies. So that is our goal. And with that, I thank you. And I appreciate this opportunity to speak here. Thank you.
Thank you, Peter. I like how capitalism works. So basically there is a big need, and you and other smart guys are having a great idea, and you are looking for hospital that will have a smart cardiologist saying, yes, I can use this software and it will help me a lot. Let's put that into our program and let's apply for grant.
Exactly.
Internal and so on. So that's how things move forward. We need to find partners who are interested. So I will use, thank you, Peter. I will use this to say to all English speaking only speakers that the rest of the presentation will not be in English. So other than me, they are free to leave, and we can continue with probably Emir Pazlibegovic leading the rest of the conference. Of course, I will stay.
Thank you very much for all speakers in excellent presentation. My congratulations enough. Nastavljamo naš simpozijum i imam zadovoljstvo da najavim našega prijatelja, sada izabranog za redovnog člana Akademije nauka i umjetnosti u Bosni i Hercegovini, šefa psihijatrijske klinike profesora doktora Dragana Babića. Dragan će nam prezentirati komorbiditet duševnih i kardiovaskularnih poremećaja, pa evo njegovih 10 minuta. Dragane, izvoli.
Dobro večer. Možete li vi uključiti moju prezentaciju?
Može. Evo ga, Dragana, izvoli.
Mogu li listati?
Može. Mi ćemo listati.
Aha. Poštovane kolegice i kolege, dragi prijatelji, sve vas lijepo pozdravljam i veselim se da smo večeras skupa i da možemo govoriti o povezanosti srca i duše, znači o komorbiditetu duševnih i kardiovaskularnih poremećaja. Posebno se zahvaljujem organizatorima ovog simpozija, a najviše predsjednik organizacijskog odbora, akademiku Emiru Pazlibegoviću, koji me je pozvao. Kad je u pitanju, može dalje, kad je u pitanju povezanost srca i duše, znači on nije nikakva novost i kroz čitavu povijest se pokušava objasniti na različite načine. Čak u Bibliji je zapisano da postoji sklad ljudske duše i srca i da on odražava puninu čovjekova bića. A čuveni liječnik Sokrat je napisao u 5. stoljeću, znači da se ne može liječiti tijelo ako se ne liječi i duša. Znači i mi u našem svakodnevnom životu, u raznim književnim djelima, pjesmama koje su napisali čuveni svjetski književnici, imamo stihove koji govore o povezanosti srca i duše. Evo samo ću jedan stih pročitati. Od Jesenjina kaže: i ništa nam srca neće ganut, duše bit će smirne po svema, ko izgodi taj ne može planut, ko ljubljaše taj ljubavi nema. I naravno mi znamo da puno pjesama ovdje ima i kod nas u Bosni i Hercegovini i u Evropi i svugdje koji povezuju srce i dušu. Dalje. Međutim, naravno nećemo govoriti ovdje o poeziji, o pjesama, ne govorit ćemo o evidence-based medicine, znači o činjenicama koje su u vezi srca, u vezi duše, o povezanosti i u činjenicama u svezi tretmana kardiovaskularnih bolesti sa komorbidnim duševnim smetnjama i obrnuto. Dalje. Znači, srce prepuklo od bola nije više samo loša pjesnička figura, da ljutnja, tjeskoba i potišnost mogu ubrzati razvoj srčanih bolesti, znanstvenici znaju već duže vrijeme. Novija istraživanja pokazuju da negiranje, potiskivanje neugodnih emocija također vrlo negativno odražava na ljude sa srčanim smetnjama. Dalje. Na ovom slajdu vidimo ono što mi praktično svi znamo, bolesti koje su povezane sa stresom. Znači, to su brojne bolesti, kad je u pitanju kardiologija, izdvojit ćemo arterijsku hipertenziju, infarkt srca, srčane tegobe i tako dalje. Postoji i preko 100 godina psihosomatska medicina, znači medicina koja se bavi isključivo povezanosti psihe sa tjelesnim bolestima i tu zadnjih par desetljeća je ta medicina jako napredovala i jedna od grana te medicine je psihokardiologija. I cjelokupni koncept psihosomatske medicine s nalaskom na holistički pristup bolesniku danas se proširuje i na druga područja medicinske znanosti, te postupno postaje zajednički koncept svih dijelova kliničke medicine. Mi imamo i psihosomatske bolesti, znači to su prave tjelesne bolesti u čijem nastanku, da bi ta bolest nastala, vrlo važnu ulogu ima psihogeni faktor. Znači radi se o tjelesnim bolestima koje pokazuju patološko-anatomske promjene i medicina koja se tim bavi zove se psihosomatska medicina. Znači obično imamo stresor koji je produžen, imamo odgovor organizma i na kraju dobijemo psihosomatsku bolest. Također postoji i behavioralna medicina i behavioralna kardiologija, znači koja je interdisciplinarno područje usmjereno na razvoj, integraciju znanja i tehnika behavioralne i biomedicinske znanosti koje se odnose na razumijevanje zdravlja i bolesti te primjene tih znanja i tehnika o prevenciji, dijagnostici i tretmanu i rehabilitaciji bolesnika. A behavioralna kardiologija znači uključuje područje behavioralne kardiologije i psihosomatske medicine, a usmjerena na rad na tradicionalnim čimbenicima rizika i na psihološkim čimbenicima rizika za nastanak i razvoj koronarne bolesti srca. Pritom podrazumijeva interdisciplinarni pristup i tim stručnjaka na čelu sa liječnikom kardiologom. Postoji i liaison konstruktivna psihijatrija, znači to je jedna grana medicine, grana psihijatrije gdje psihijatar praktično radi na odjelu za interne medicine, ovdje konkretno na odjelu kardiologije i tu, znači, on ne smije zaboraviti da bolesnik ima i dušu i ne samo tijelo i da su ti srčane bolesnici nerijetko posljedica, jedan od važnih uzroka u nastanku tih srčanih tegoba i bolesti, znači da je to neke psihičke smetnje. Komorbiditet duševnih i tjelesnih poremećaja je više pravilo nego iznimka, te je suvremeni trend u liječenju sve češće na načelima integralne i holističke medicine. Američko istraživanje provedeno na 13.708 bolesnika s koronarnom bolesti srca pokazala je da depresija kod tih bolesnika povećava rizik od razvoja zatajenja srca. Američki kardiolozi ukazuju da su psihološki problemi, stres i tjeskoba ključni faktori koji pridonose razvoju kardiovaskularnih bolesti. Znači, oni su zapisali, povedete li stres, šanse su vam za 60% bolje. Osobe koje uspijaju smanjiti razinu stresa ili ga drže pod nadzorom imaju 60% manje izglede da dožive srčani udar i da podlegnu bolesti od onih koji su nervozni i ne mogu se kontrolirati. Od 516 srčanih bolesnika koji su sudjelovali u istraživanju, 44 je preživjelo srčani napad, a 19 je umrlo u 3 do 4 godine njihova praćenja. Dobro poznatu vezu između depresije i bolesti srca, američki znanstvenici su produbili identificiranje simptoma depresije koji mogu ukazati na poteškoće sa zdravljem kardiovaskularnih sustava. Istraživači sa Indiana University su utvrdili da određeni fizički simptomi depresije, poput gubitka apetita, poteškoća sa spavanjem ili umora, mogu ukazati na veći rizik za bolesti srca. Kad je u pitanju povezanost depresije i kardiovaskularne bolesti, znači mi imamo tu da su depresija i kardiovaskularne bolesti dva vodeća uzroka o nesposobnosti u svijetu. Veliki depresivni poremećaj ima 20% bolesnika sa koronarnom bolešću srca, a još 20% ima depresivne simptome. Neovisni faktor rizika za razvoj kardiovaskularne bolesti u zdravih osoba, znači depresija je faktor rizika za nastanak koronarne bolesti srca i pogoršava prognozu kod već oboljelih osoba i pogoršava ishod liječenja u bolesnika sa kardiovaskularnim bolestima. Koji su uzroci kardiovaskularnih bolesti? Naravno, ja neću ulaziti u nikakve stomatske ili organske uzroke, ali vidite, između ostalog, postoji tip ličnosti, tip A. To su osobe koje su vrlo ambiciozne, koje žele da uspiju, koje puno rade, one imaju strpljenje, one su vazda u žurbi, one zapostave sebe i na kraju nerijetko dobiju koronarnu bolest ili u početku visok krvni tlak i tako dalje. Zatim, da bi nastao visok krvni tlak, znači to češće postoji kod osoba koje su pasivno ovisne, koje imaju agresivne tendence, koje potiskuju neprijateljstva, koje imaju način na reakciju na stres, a i aritmije, nerijetko uzrok pravih kardijalnih aritmija je bezrazložni strah, anksioznost ili okolinski stres. Kad su u pitanju psihosocijalni čimbenici u razvoju kardiovaskularnih bolesti, znači mogu biti nepovoljni i protektivni efekti. Nepovoljni su loš socioekonomski status, veliko opterećenje na poslu, niski stupanj društvene aktivnosti, depresija i česta ljutnja. Vidite sve, znači psihički simptomi, a protektivni su društvena potpora i potpora samom sebi. Duševni poremećaji često idu skupa u komorbiditetu sa različitim poremećajem metabolizma i tjelesnim bolestima, uključujući i koronarnu bolest. Kako mnoge bolesti mogu imati preklapajuće patofiziološke mehanizme, u takvim slučajevima informacije dobivene proučavanjem jedne bolesti mogu se promijeniti na drugu bolest. Proučavanje moguće povezanosti različitih kardioloških i psihijatrijskih poremećaja može značajno pridonijeti boljem i holističkom razumijevanju i uspješnijem liječenju komorbiditetnih poremećaja i bolesti u suvremenoj medicini. Depresivni i anksiozni poremećaji su bolest sa 1000 lica koji se često ne prepoznaju u primarnoj zdravstvenoj zaštiti i nerijetko su u prvom planu tjelesni simptomi, a onda to ide se u detaljnu somatsku obradu, pri čemu se troši novac, gubi vrijeme, narušava povjerenje pacijenta i znači vrlo je važno da se to prepozna da se uputi i psihijatru ili psihologu. U stručnoj literaturi posljednjih godina sve je više dokaza o visokoj učestalosti metaboličkih poremećaja u psihijatrijskih bolesnika i somatske bolesti kao što su pretilost, hiperlipidemija, hipertenzija, dijabetes mellitus tip 2 su u zadnje vrijeme sve više shvaćaju kao značajna komorbidna stanja u pacijenta sa težim mentalnim bolestima. Da li su ovi poremećaji dio samog patološkog procesa, mentalnih bolesti kroz povećan stres i inflamatorni proces, genetsku vulnerabilnost ili okolišne faktore, ili su posljedica liječenja bolesti, još uvijek nije do kraja jasno. Tek u zadnje vrijeme su u istraživanjima na području psihijatrije počelo promatrati ovakva stanja u kontekstu metaboličkog sindroma. U osoba sa metaboličkim sindromom općenito je povećana smrtnost, a osobito smrtnost kod kardiovaskularnih bolesti. Mi smo prije 16-17 godina imali jedan projekt koji je podržala Federalno ministarstvo zdravstva, gdje smo ispitivali somatske bolesti u psihijatrijskih bolesnika, imali smo 701 ispitanika, tu smo bili uključeni nas nekoliko, pa smo ispitivali šizofreniju, metabolički sindrom, PTSP, metabolički sindrom, depresiju, jedan ginekolog je psihičke poremećaje u žena s patologijom trudnoće i tako dalje. Ovo su rezultati. Znači, mi smo dobili rezultate da kod šizofrenije bilo je 450 ispitanika, njih 25,6% imalo je hipertenziju. Kod PTSP-a 32,2%, a kod depresije 58,3%, znači uz depresiju je imalo i kardijalni problem hipertenzije. I na kraju, umjesto zaključka, prema današnjim spoznajama, možemo sa sigurnošću tvrditi da stres u manjeg broja osoba dovodi do pozitivnih posljedica, a značajno većeg broja ljudi stres ima negativne konotacije i na psihičko i na tjelesno stanje. Malo je bilo istraživanja koja su nastojala otkriti je li moguće poboljšati kardiovaskularno stanje osobe tako što se utvrdi njezino psihološko stanje i psihoaktivnim lijekovima i psihoterapijom smanjiti različite psihičke simptome. Najnovije studije trebala bi potaknuti kardiologe da u liječenju srca i krvnih žila ne zanemare ni psihološke probleme svojih bolesnika. S druge strane, potrebno da psihijatri razmišljaju o mogućim kardiovaskularnim smetnjama i ne prepisuju sve simptome psihičkim, te da na vrijeme pacijente upute na kardiološku obradu i liječenje. Rehabilitacijski tretman kardiovaskularnih bolesnika koji uključuje i psihosocijalne intervencije uspješniji su od onih koji ih ne uključuju. Poboljšanje se ne odnosi samo na psihičko stanje bolesnika, nego i na medicinske parametre i prognozu kardiovaskularnih bolesti. Hvala lijepa.
Hvala Dragane. Ovim si pokazao da je prezentacija Amita Šaha i tvoja baš fino se uklopila i predstavila ovaj problem stresa, problem psihogenih bolesti na kardiovaskularni sistem. Hvala ti još jednom i idemo dalje. Naša Samra Međedović je odsutna, iskrsno joj je hitan put, tako da ćemo njenu prezentaciju staviti kao i poster. A slijedi Dijana Zelenika, naša doktorica, šef kardiološkog odjela u Sveučilišnoj kliničkoj bolnici Mostar na internoj klinici. Ona će nam predstaviti nekompakcijsku kardiomiopatiju, prikaz slučaja. Dijana, izvoli. Dijana.
Evo, ne znam da li sam uspjela, da li me vidite. Nadam se da jeste.
Ajde, šeruj se.
Ja ću probati svoju prezentaciju. Samo čas. Jel' vidite?
Još ne vidimo.
Pa koji si vrago, dobijete karticu za pregled.
Vidimo te.
Vidite mene, ali hoću da dignem prezentaciju i sad mi se negdje izgubila, mati mila. Sad je uopće ne vidim ni ja dole, a bila sam je sebi bar digla. Podijeli. Samo čas.
Vidimo.
Ja, ali nisam htjela to, htjela sam u stvari...
Moli, mi da ti postavimo.
Pa izgleda da će morat. Ne znam uopće šta mi se dogodilo.
Evo, Adil će to.
Da.
Malo stopiraj svoj share.
Evo ga, stop sharing. Ja sam stopirala, ali uopće mi nije jasno šta je problem. Evo dok naši stručnjaci rade ovo, ako me čujete, nadam se da jeste, ja se želim zahvaliti Emiru opet što je ovako bio ekspeditivan i što nas je opet okupio. Iako nije na odjelu, on to vrlo učinkovito radi, tako da kad smo razgovarali kao imaging metode su u pitanju, ja sam tih dana imala pacijenta sa jednom nekompaktnom kardiomiopatijom, pa sam ga željela prikazati sa ciljem da se svi prisjetimo te dijagnoze, ne auditorij možda koji je na nekoj razini predavača i tako dalje s akademskim titulama, nego možda više na ljude u primarnoj i sekundarnoj zdravstvenoj zaštiti koji će dobiti ova otpusna pisma i vidjeti jednu ovakvu dijagnozu, a možda im neće biti jasno o čemu se radi. Evo ga, znači u pitanju je nekompaktna ili nekompakcijska kardiomiopatija. Može dalje. Jel me čujete?
Čujemo te.
Aha, ok. Znači o čemu se radi? Prema definiciji Američkog udruženja kardiologa, to je u biti jedna nasljedna genetski uzrokovana kardiomiopatija, a Svjetska zdravstvena organizacija i Europsko udruženje kardiologa je svrstava kao nekvalificiranu kardiomiopatiju. U pitanju su nasljedna bolest, znači sa brojnim komplikacijama. Isticana je prvi puta još 1969. godine, a praktično 1990. godine je ovaj pojam uveden u svakodnevnu kliničku praksu. Može dalje. Što se tiče ove bolesti, ona je povezana sa brojnim komplikacijama, prvenstveno sa kardijalnom dekompenzacijom, odnosno znakovima zatajivanja lijeve klijetke, zatim sa brojnim srčanim aritmijama i embolijskim događanjima, a nerijetko i iznenadnom srčanom smrću. Kao što je to i koronarna bolest, tako i ova bolest, nažalost, evo nešto češće zahvata muški spol. Što se tiče simptoma, nažalost, pojavljuju se tek u odrasloj dobi, rijetko je bolest simptomatska, a što se tiče dijagnostike, tu su slikovne metode, imaging metode, u stvari one koje su pod broj 1, prvenstveno Doppler ehokardiografija, međutim u određenim situacijama kad se ne može baš prikazati trabekulacija miokarda, onda je potrebno učiniti ili magnetsku rezonancu ili CT srca. Može dalje.
5 sekundi ti treba od ove komande do...
Slobodno, neka prati kako ja govorim, tako da može vrtiti slajdove da ja to ne govorim. Što se tiče ehokardiografskih kriterija koji su nama najbitniji, znači ono što je vrlo bitno u ovoj kardiomiopatiji, to je nalaz trabekulacija lijeve klijetke. Obično se to nalazi u predjelu apeksa, ali i medijalnog dijela kako inferiorne, tako i lateralne stijenke. A taj odnos nekompaktnog i kompaktnog dijela miokarda je u ovoj vrsti kardiomiopatije veći od 2. Tipičan je nalaz, znači, tih dubokih, multiplih intratrabekularnih recezusa koji su povezani sa šupljinom klijetke, a zadebljanje miokarda u sistoli je manje od 8 mm. Diferencijalna dijagnoza zna praviti probleme kod ove kardiomiopatije. U diferencijalnoj dijagnozi su prvenstveno dilatativna kardiomiopatija, zatim su tu apikalne forme hipertrofične kardiomiopatije, dalje hipertenzivna. Može problem učiniti u diferencijalnoj dijagnozi fibroelastoza endokarda, abnormalne korde ili čak tromb u vršku samog srca. Rijeđe su neka druga stanja u pitanju. Što se tiče studija, imamo rezultate jedne švicarske studije gdje je smrtnost bolesnika sa nekompaktnom kardiomiopatijom iznosila 35%, a 12% bolesnika je čak bilo podvrgnuto transplantaciji srca. Daljim praćenjem ove skupine bolesnika zaključeno je da je petogodišnje preživljavanje otprilike 88%. Što se tiče elektrokardiografskih promjena, njih sam spomenula, one mogu biti dosta nespecifične u smislu hipertrofije lijeve klijetke ili negativnih T valova. Dalje su tu nespecifične promjene repolarizacije ili patološke osi, atrioventrikularne i intraventrikularne smetnje provođenja, pa sve do produženog PQ intervala, QT intervala i poremećaj repolarizacije koji predstavljaju neovisne čimbenike rizika za loš ishod bolesnika sa nekompaktnom kardiomiopatijom. Što se tiče studija još koje su poznate, Ashley suradnice su zabilježili elektrokardiografske malformacije čak u 94% odraslih bolesnika, a 56% njih su u stvari intraventrikularne smetnje provođenja. Što se tiče atrijske fibrilacije koju je imao i moj pacijent, evo vidimo da se nalazi negdje od 5 do 29%, a ventrikularna tahikardija jako zastupljena i nalazi se u 18 do 47% bolesnika sa nekompaktnom kardiomiopatijom. 18% bolesnika završi iznenadnom srčanom smrću, najčešće je u pitanju aritmogena srčana smrt od nekompaktne kardiomiopatije. Kao jedna od komplikacija osim popuštanja srca i smetnji provođenja spomenula sam i sistemske tromboembolije. Jasno da one mogu biti na razini moždanog krvotoka u smislu infarkta ili tije, isto tako u području splanhnikusa u smislu mezenterijalnog infarkta ili infarkta slezene i bubrega, ili se može raditi o periferiji, odnosno o tromboembolijskim komplikacijama ekstremiteta. Što se tiče tih tromboembolijskih događanja, ne moraju biti samo u pitanju, ne mora sama isključivo nekompaktna kardiomiopatija, jer i poremećaj srčanog ritma kao što je atrijska fibrilacija znamo da je faktor rizika koji može dovesti do tromboembolijskih incidenata i da u 3/4 slučajeva se radi o moždanom udaru. Što se tiče liječenja, već iz ovoga svega što sam rekla da dovodi do popuštanja srca, do poremećaja srčanog ritma i do tromboembolijskih komplikacija, liječenje je i usmjereno u tom smislu da se liječe ove tri skupine manifestacija. Znači u terapiji ćemo uključiti ACE inhibitore ili blokatore receptora angiotenzina 2, beta-adrenergičke receptore. Jasno da nam je potrebna i diuretska terapija zbog ovih tromboembolijskih događaja i u pitanju su i antikoagulantni lijekovi. Kod pojedinih bolesnika kod kojih dođe do izrazite kardijalne dekompenzacije sa niskom ekcijskom frakcijom i koji imaju maligne oblike aritmija, može biti potrebna ugradnja kardioverter defibrilatora, a ukoliko se radi o smetnjama provođenja može se ugraditi elektrostimulator srca, odnosno pacemaker. Međutim, ukoliko usprkos svim ovim metodama liječenja koje sam spomenula nema poboljšanja srčane funkcije, onda je takav pacijent kandidat za transplantaciju srca. I evo prikaz jednog takvog slučaja. Radilo se o bolesniku ovih inicijala, relativno mlad, 76. godište, od ranije je imao inzulin neovisnu šećernu bolest. On je upućen na hospitalizaciju zbog zaduhe, imao je glavobolju i osjećaj trnjenja lijeve polovice tijela. U EKG-u je bila fibrilacija atrija sa brzim odgovorom ventrikla do 170 u minuti, ali ventrikularna ekstrasistolija, čak povremeno tipa bigeminije i vesica u paru. Što se tiče njegovih fizikalnog pregleda, evo imamo body mass index koji je zadovoljavajući s obzirom na našu populaciju. Eupnoičan je bio u mirovanju, ono što je bilo patološko je nalaz na plućima, bazalno su se čuli vlažni hropci, jasno fibrilacija atrija daje nalaz u smislu apsolutne aritmije. Tlak je bio dosta visoki, 180-100, uz ovaj subjektivni osjećaj trnjenja polovice tijela, što je izazivalo sumnju na hipertenzivnu encefalopatiju ili čak kakav tromboembolijski incident s obzirom na fibrilaciju atrija sa brzim ventrikularnim odgovorom. Što se tiče laboratorijskih nalaza, nije bilo nekakvih odstupanja od normalnih vrijednosti. Rentgen pluća, evo imamo sliku rentgena pluća, znači to su obostrani znakovi kardijalne dekompenzacije, znači obostrano je zasjenjen plućni parenhim i u donjim i srednjim plućnim poljima, srčana sjena je uvećana i jasno ove opisane promjene idu u prilog zastojnim promjenama. Što se tiče ultrazvuka srca, on je ukazao na dilataciju lijevog atrija i na koncentričnu hipertrofiju stijenki lijeve klijetke, međutim ono što je bilo uočljivo je ta partikularnost, trabekularnost apikalnih dijelova lijeve klijetke i spontani ehokontrast, što je i bilo karakteristično za nekompaktnu kardiomiopatiju. Tu je mitralna i trikuspidna regurgitacija bez plućne hipertenzije uz sniženje ekcijske frakcije na 43% bez perikardijalnog izljeva. Ovo je klasična slika uzeta sa interneta, jedne nekompaktne kardiomiopatije. Iza je sada sljedeći slajd je slika koju ja nisam imala papira i nisam uopće razmišljala da ću nekad prezentirati tog pacijenta na jednom ovakvom simpozijumu. Možete vi sljedeću sliku pokazati. Slika na mobitelom mi nije baš najbolja mi ispala jer nisam imala namjeru upotrijebiti, ali sam je ipak stavila, vidi se i hipertrofija stijenki, vidi se ta trabekularnost apikalnog dijela, što je tipično za nekompaktnu kardiomiopatiju. Učinili smo MSCT mozga, već sam rekla da je postojala sumnja na ili hipertenzivnu encefalopatiju ili neko događanje s obzirom na kliničku sliku pacijenta, međutim nije bilo nekakvih niti znakova ishemije, niti hemoragijskih, niti prikaza hemoragije na samom CT-u mozga. Neke kronične vaskularne lezije su bile, ali nije bilo niti hidrocefalusa, znači nije bilo znakova u smislu cerebrovaskularnog incidenta. Učinjen je i Doppler krvnih žila vrata, naravno to nam uvijek neurolozi traže, tu nije bilo nekakvih posebnih promjena osim rubnih i karakterističnih za dob. Što se tiče terapije, već sam spomenula terapiju kardijalne dekompenzacije sa ACE inhibitorima, beta blokatorima, uz diuretsku terapiju, ne samo zbog fibrilacije atrija jer se on konvertirao u sinusni ritam, znači dobio je noake, ne samo zbog fibrilacije atrija, nego upravo zbog nekompaktne kardiomiopatije i onih brojnih silnih trabekula koje su prema današnjim spoznajama ishodište tromboembolijskih incidenata. I onako, za nekakav zaključak da nekompaktna kardiomiopatija ipak nije tako rijedak slučaj i da u zadnje vrijeme je učestalost u porastu, ali mislim da je to zahvaljujući upravo ovim spoznajama da takva kardiomiopatija postoji i zahvaljujući metodama slikovnog prikaza. Tako da u zadnje vrijeme imamo slučajeva. Ja sam ovog pacijenta zamolila, friško mi je bio, ali ima 2 sina, rekla sam da je muški spol nešto učestaliji, pa da dođu i oni na pregled, još se nisu pojavili, da li od straha ili nečega, to ćemo još vidjeti. Što se tiče nekompaktne kardiomiopatije, mišljenje da ipak još uvijek nužno jedno prospektivno multicentrično kliničko istraživanje koje će rezultirati izjednačenim dijagnostičkim i terapijskim postupcima, jasno samim tim i boljim ishodom bolesnika sa nekompaktnom kardiomiopatijom. I hvala vam na pažnji. Evo, da nije bilo tehničkih problema, vjerojatno bi završila u roku tih 10 minuta.
Hvala Dijana na interesantnoj prezentaciji pacijenta i na podsjećanju kako se sa našim postojećim cardiac imagingom u našoj sveučilišnoj kliničkoj bolnici može ipak uraditi dosta. Još jednom ti hvala. I sljedeći je Zrinko Prskalo koji me zamolio zbog njegovih porodičnih problema, nije stigao da ovo završi, pa ćemo preći na Ivana Jurića. Ivane, jesi li na linku? Ivane? Ivane, da li me čuješ? Izgleda Ivan se nije linkovo, onda ćemo njegovu prezentaciju staviti u poster i sada slijedi izlaganje Adisa Muslibegovića, ehokardiografska evaluacija dilatacijske postmiokardične kardiomiopatije nakon COVID-19 infekcije. Adis je nastavio ovu svoju studiju istraživanja COVID pacijenata u svojoj bolnici. Adis, izvoli.
Ja se zahvaljujem prije svega na pozivu. Moj rad večeras predstavlja tokom trogodišnjeg perioda trajanja pandemije COVID-19 infekcije uočio sam veliki broj pacijenata sa miokarditicom tokom akutne faze, neposredno nakon nje, a u kasnijem periodu razvila se dilatacijska kardiomiopatija. Rad predstavlja retrospektivnu, prospektivnu studiju čiji je zadatak da evaluira postojeća iskustva te ako je moguće promijeni pristup ovim pacijentima zbog karakteristika postmiokardične kardiomiopatije. U radu je predstavljeno 49 pacijenata diferencirani po dobnim spornim karakteristikama, a nakon toga po stepenu dilatacije lijeve komore kroz pojedinačni, jednogodišnji, dvogodišnji i evo sad u toku trogodišnji period, te poststoričnu, odnosno dijastoličnu disfunkciju lijeve komore. Nakon toga kivnim doplarom lateralnog, odnosno septalnog dijela mitralnog prstena, globalnog strejna, asistolnog i dijastolnog, regionalnog do preciznog mjerenja karakteristika vijabilnosti fibroziranog dijela miokarda u odnosu na onaj vijabilni preko kivnog doplera strejna, strain rate metoda. Diskusija je predstavljena preko grafikona koji pokazuju starosnu polnu strukturu sa predominacijom starijih pacijenata iznad 60 godina, većom zastupljenosti muškog spola u svim dobnim skupinama. Evo ovdje se vidi na toj tabeli grafikon. U tabeli 2 prikazuje porast dijastolne dimenzije lijevog ventrikula u trogodišnjem periodu, obzirom da se radi o istim pacijentima, vidi se kako dijastolna dimenzija lijevog ventrikula kod tih pacijenata raste iznad 6 cm. Tabela 3 prikazuje stepen dijastolične disfunkcije lijevog ventrikula u trogodišnjem periodu. Znači ovdje se vidi kako otprilike naročito ta dijastolna disfunkcija drugog stepena za diferencijaciju nam je koristio baš taj kivni dopler. Tabela i grafikon 4 prikazuju sistoličnu disfunkciju lijevog ventrikula kroz vrijeme, kako ona pada kroz vrijeme, tako da ova ispod 40% predstavlja signifikantnu srčanu slabost, eto ona je sve zastupljenija kako vrijeme odmiče. Tabela 5 i grafikon 5 prikazuju promjene brzine preko kivnog dopla, lateralnog, odnosno medijalnog dijela mitralnog prstena, što više služi za diferencijaciju dijastolične disfunkcije neovisno o punjenju lijevog ventrikla. Tabela 6 prikazuje redukciju globalnog strejna lijeve komore kroz vrijeme. Evo, mi smo ovdje radili kako vrijeme odmiče, tako taj globalni strejn pada. Ova tabela 7 je najkompleksnija u kojoj se prikazuju karakteristike vijabilnosti miokarda u apsolutnim i korigiranim vrijednostima i to učinjeni na mjestu najizrazitije fibroze tog spektru trackinga i u komparaciji sa vijabilnim dijelom, odnosno ono što nam se činilo intaktnim, ono što nije promijenjeno. Inače, miokarditis u sklopu COVID-a je uglavnom fokalni, nije difuzni, i mi smo te podatke iznijeli ovdje u ovoj tabeli, pa eto, mi smo radili taj kivni dopler fibroziranog i to pod navodnim znacima urednog dijela. Radili smo strain fibrozu sistolnu, kao isto tako urednog, i ovo vidi se kako se mijenjaju parametri kroz vrijeme, a i strain rate koji je najspecifičniji parametar u određivanju karakteristika vijabilnosti miokarda pokazuje kroz vrijeme redukciju. Evo ovdje se to na grafikonu naročito dobro primijeti, a ovo je ta nekakva šema koja je poslužila kao inspiracija za sve ovo što se radi, pa i ove imaging metode su prije svega doprinijele dotle da mi sve više otkrivamo pojedinačnih stvari na onome što smo mislili da je ranije dosta jednostavno, šturo i sa puno manje parametara nego sad. Ovdje vidimo neke slike, ovo je recimo TDI, septalnog dijela mitralnog prstena, evo recimo i ovdje kaže gdje nam prikazuju dijastoličnu disfunkciju, evo ovdje dilataciju lijevog ventrikla, pa evo ovdje čak jednu vegetaciju vidimo na mitralnom prstenu. Evo ovdje opet imam tkivni dopler. Evo ovdje imamo obojni emodio. Zaključci. Virus COVID-19 izrazito kardiotropan, a razvoj postmiokardične kardiomiopatije ima puno brži tuk nego drugim etiološkim momentima oštećenja srca. Ehokardiografska evaluacija prvenstveno novim metodima konkretnije kalkulira parametrima regionalne kinetike upalom oštećenog dijela, ali i drugim područjima što indirektno ukazuje na postojanje lezije, vulnerabilnog protoka energetskog i metaboličkog disbalansa miokarda. Navedena promjena implicira razvoj novih metoda modulacije metaboličkog vaskularnog energetskog profila u liječenju posupalnih miokardnih oboljenja. Ja sam napomenuo kroz prezentaciju da se radi o fokalnom oštećenju miokarda, međutim vidimo, kaže, da se radi o globalnom oštećenju, što je rezultat ovih promjena na srcu.
Hvala, Adis, na interesantnoj prezentaciji ovog svog trogodišnjeg istraživanja, studije. Ovaj follow-up je rijedak u našim prikazima na ovim sastancima, pa evo još jedna čestitka i podrška da vidimo i za 4-5 godina šta će biti sa ovim našim pacijentima koji su imali COVID-19. I evo na kraju prezentacija moja o cardiac imagingu u INOCA. Još jednom vas pozdravljam u ime organizacionog odbora i u ime ovih svih učesnika, sponzora i pokrovitelja. Još jednom vam čestitam rođendan sutrašnji 75. Svjetske zdravstvene organizacije i 7. april, Svjetski dan zdravlja. INOCA je novi relativno termin koji je ušao u svakodnevnu praksu u kardiologiji. To je ishemija bez opstrukcije koronarnih arterija i traži dodatne imaging metode da bi se odredili njeni endotipovi. Tako da imamo metode FFR, znači frakcionalni rezervni protok, CFR, koronarni rezervni protok, IMR, indeks te mikrocirkulatorne rezistencije, koji je abnormalan ako je viši od 20 ili jednak 25%. To je hiperemička mikrovaskularna rezistencija, HMR, koja ako je veća od 1,9 je značajna. Tu su acetilholinski testovi i adenozinski testovi, EKG dijagnostika, koronarna mikrovaskularna disfunkcija i koronarna arterijska bolest koje su često praćene i sa INOCom. Tako da imamo ovi nekoliko tipova, to je prva je tip mikrovaskularna angina, druga je koronarni vazospazam, kombinovana kardiomikrovaskularna disfunkcija i spazam, nekardijalna bol u prsima i neobstruktivna koronarna arterijska bolest. Vidite da za mikrovaskularnu anginu imamo najčešće pozitivne ove parametre ovih rezervnih protoka. Imamo u koronarnom vazospazmu izostaje CFR, IMR i HMR, dok su ovi ostali pozitivni. U kombinovanim imamo sve izved CFR manji od 2 i EKG nema prateći simptoma, dok nekardijalni bol je praćen sa povećanim protokom od 0, rezervnim protokom od 0,80 i neobstruktivna koronarna arterijska bolest koja je i plus i minus. Ovo je poznati model koji smo mi predstavili u našoj posljednjoj knjizi o infarktu miokarda, gdje vidimo skelet vaskulature srca gdje vidimo glavne arterije, aortu, plućne arterije, aurikule i vidimo sada ove naše glavne koronarne arterije i vidite ovu mikrovaskulaturu, to je kao spužva u čitavom našem miokardu. To u patološkom smislu izgleda ovako, gdje imamo ateroskleroske plakove na glavnim krvnim sudovima, ali vidimo da ta mikrovaskulatura prati ove glavne ogranke koronarnih arterija. Šta je klinički važnost ove mikrocirkulacije? Ona je glavna determinanta miokardnog protoka, objašnjava anatomski osnov za i predikciju frakcionalnog flow rezerva FFR, objašnjava diskrepance između nehiperemijskih parametara i FFR, signifikantan uticaj na prognozu, klinički važan na šokno stanje i mogući cilj za nove terapeutske pristupe, naročito u ST elevaciji miokardnog infarkta. Vazospastični vaskularni poremećaji zahvaćaju najčešće površne epikardijalne koronarne arterije. One nisu, tačan mehanizam nije dobro prostudiran, tako da često varira u patogenezi pojedinih zemalja, od 24% u Japanu do 5% u Americi. Vazospastična vaskularna angina, poremećaji su češći kod muškaraca nego kod žena. Pušenje je faktor rizika za vazospastičnu anginu, a terapija je kalcijum kanal blokeri i nitrati. Prevalenca inoke, evo vidite, više od 50% je izolirana mikrovaskularna angina, negdje oko šestine je miješana mikrovaskularna i vazospastična angina. Vazospastična angina je negdje u šestine slučajeva, a ne kardijalni u 1/8. Incidenca inoke posljednji najmanje 3 do 4 miliona amerikanskih žena i muškaraca ima stabilnu inoku, dok su cijene liječenja iste kao i za opstruktivnu koronarnu arterijsku bolest. To je važno da se naglasi da se ne zanemaruje njen značaj. Više od 60% stabilnih inoka pacijenata su dokumentirali svoju kardiomikrovaskularnu disfunkciju. Ona je vezana i za starost kao tradicionalne faktore rizika i ima lošiju prognozu. Ženski pol je skoro signifikantno udružen sa kardiomikrovaskularnom disfunkcijom sa značajnim 0,98 do 1,4 confidence intervala. Visoka prevalenca endotelijalne i prema neendotelijalnom zavisnom kardiomikrovaskularnom disfunkcijom je vezana za pacijente sa inokom. To vidite Heroskovići u Jaha objavljen članak 2023. Znači to je taze, habe što se kaže. Inoka žene u toku 10-godišnjeg perioda imaju rizik za smrt 17% prema 11%, što je značajno, i 10 prema 6% kod onih sa normalnim koronarnim arterijama. Invazivna i prema neinvazivnoj koronarnoj angiografiji se pokazala neznačajno visok je stepen nakon revaskularizacije i kardiovaskularnih događaja nakon revaskularizacije. Znači, kardiomikrovaskularna disfunkcija može biti inoka, vazospastična angina, koronarna arterijska bolest, srčana slabost sa očuvanom ejekcionalnom frakcijom, tako cubov kardiomiopatija, može biti akutni koronarni sindrom kao obična angina ili kardiomiopatija. Invazivna evaluacija inoke se sastoji od zlatnog standarda koronarne angiografije, gdje se utvrđuje taj stanje, da li postoji plak ili ne, da li postoji stenoza ili ne. Zatim se mjere rezervni protoci, frakcionirani flow rezerv i koronarni flow rezerv i indeks. I vazoreaktivnost sa acetilholinom. Ako su ti parametri FFR veći od 0,8, CFR veći od 2 i IMR manji od 25, onda treba ići na da se ne radi o angini, da nema ishemije, da se snimi EKG i nema kardijalne kardiomiopatije. Ako je FFR veći od 0,8, manji CFR od 2, a IMR veći od 25, ta dijaredukcija je veća od 90% i mikrovaskularna angina sa vazospasičnom anginom je vjerovatnija. Evo koje su to mjerenja na koronarografiji kada angio mjerimo taj IMR i kako ga mjerimo automatski uz pomoć ovih Abbott novih uređaja i kako imamo i sada novu i termodilocionu metodu koja se slaže sa angiografskim metodama i nema neke veće statističke razlike u ovim studijama koje je prezentirala Meja Renterija i saradnici. I tretman algoritma, znači kontrola rizikofaktora koji se davanje beta blokatora i kalciju antagonista, uključivanje ranolazina, ksantina, ACE inhibitora, ivabradina i nikorandila. Dalje, ako i dalje perzistira, da tu su i ksantini, triciklični antidepresivi ili intervencije na koronarnim arterijama. Postoji jedan jaz između saznanja i rezultata inoka pacijenata koji sada zahtijevaju da se u zaključku može reći da sve veći broj stabilnih inoka pacijenata i uočena povišena stopa MES skreće pažnju na neko važnih praznina u znanju. Čini se da postojeći alati za procjenu rizika primarne i sekundarne prevencije ne predviđaju MES rizik kod inoka pacijenata, zato je potrebna istraga kako bi se posebno pozabavili alatima za tačnu procjenu rizika kod ovih pacijenata. Izgleda da postoji dijagnostička i terapijska nesigurnost kod inoka pacijenata s potencijalno neprimjereno niskim stopama kardiovaskularne terapije i s obzirom na dokumentirano opterećenja aterosklerozom i ishemijom. Smjernice za primarno ili sekundarno liječenje zasnovane na dokazima ne odnose se posebno na ovu populaciju, što ukazuje na odsustvo ispitivanja kardiovaskularnih ishoda kod inoka pacijenata. Ovaj važan jaz u znanju mora se riješiti kako bi se prednjačilo ovo novo pitanje i potrebni su dalja klinička ispitivanja osmišljena da testiraju učinak optimalne medicinske terapije na inoka pacijente. Ovdje sam u prilogu dao rezultate studija, pa vi možete pogledati i preporuke ovog američkog udruženja kardiologa, koje je doduše iz 2021. godine, sada će vjerovatno izaći neke nove preporuke koje očekujemo na sljedećem kongresu kardiologa. Hvala lijepo. Sada, ukoliko ima pitanja na sve ove prezentacije ili komentara, jer imamo još 5 minuta za diskusiju, možete postaviti pitanja pa ćemo se ovako dogovarati. Evo, negdje oko 40-ak je još na linku kolega koji nas prate i slušaju, pa evo, izvolite. Ima li pitanja za bilo koju od ovih prezentacija ili komentara ili nekih prijedloga?
Ima, profesor Babić je digao ruku.
Profesore Babiću, izvolite.
Evo, ja nemam pitanja, ja imam samo komentar i ja sam do sada u svojoj karijeri organizirao puno simpozija i nekih drugih stručnih događanja i mislim da je ovo jedan vrlo kvalitetan simpozij i mislim da u medicini treba sve više organizirati sličnih simpozija gdje se u neku ruku organizira da se govori i o tijelu, ovdje konkretno o srcu, ali i o duši ljudskoj, tako, jer čovjek se sastoji od tijela i duše. Ja čestitam i zahvaljujem se organizatorima, posebno akademiku Fazlibegoviću, i mislim da je ovo jedan kvalitetan simpozij i slušajući ove profesore iz SAD-a i Indije i ove naše domaće, mislim da smo svi imali koristi, da smo nešto naučili i da je ovo dobro. Pa akademiče Fazlibegović, čestitam i drago mi je, imao čast da i ja nešto kažem kao psihijatar o povezanosti srca i duše.
Hvala, Dragane, na komplimentima i evo, očekivao sam da će biti neki pitanja, ali evo, mislim da je povezanost i interdisciplinarnost u pristupu ono što krasi udruženje kardiologa. Mi često uključujemo naše i pulmologe i anesteziologe i opšte prakse profesore koji nam onda prezentiraju jednu kompletnu problematiku i vas da idemo iz jedne oblasti kardiologije u drugu. Evo, ovo je prilika i da najavim, na primjer, za 29. septembar, Svjetski dan srca, da ćemo imati pored novina sa Evropskih američkih kongresa i temu u žiži interesa srčana slabost sa očuvanom ekcijnom frakcijom. Pa evo, možete se pripremiti ako imate neke ideje da nam sugerišete. Dolazi nam profesor Četin Erol iz Turske, bivši predsjednik Udruženja kardiologa Turske i predsjednik ehokardiografskog udruženja, Evropskog udruženja kardiologa. Znači, jedno veliko ime evropske i svjetske kardiologije i dolazi nam u Mostar, tako da se trebamo spremiti da ga dočekamo i da mu prezentiramo ova naša dosadašnja iskustva o našem radu. Ima li još komentara, pitanja? Ako nema, ja bi se zahvalio svima, posebno mom ko-čermenu Emiru Veledaru u Majamiju, da mu se zahvalim na podršci, da mu se zahvalim da smo uspješno doveli do kraja ovaj naš simpozijum. Zahvaljujem se i njegovim i našim prijateljima koje smo angažovali. Mislim da su bile prezentacije na visokom nivou. Žao mi je što su kolega Zrinko Prskalo, Ivan Jurić i Dijana Zelenika, Samra Međedović izostali i njihove prezentacije. Vidjet ćemo šta je to bilo sa njima. Sve ove prezentacije će biti postavljene na našu web stranicu, pa i možete i detaljno pregledati i koristiti u svojoj svakodnevnoj praksi. Snimak ovoga će biti postavljen također na našoj web stranici. Knjiga apstrakta i biografija i fotografija naših učesnika će također biti čim prije gotova. Evo, zamolit ćemo Adila da to bude što prije. Ova knjiga apstrakta se može pogledati od prošlog simpozijuma na našoj web stranici, tako da možete pogledati. Evo, to je sve i molim još jednom, oni koji nisu u toku prijavljivanja dali svoju tačnu adresu, neće moći dobiti ovaj sertifikat koji ćemo proslijediti poštom, tako da evo, da znate ili se javite da
Imenjače, mute si. Treba da se odklikneš.
Jesam li ovo sve pričao bez?
Otprilike do pola, dok si rekao da se ljudi jave.
Dobro, onda su uglavnom čuli, znači ovo da se jave ako nisu pravilnu adresu stavili, da se jave i da onda možemo taj problem riješiti sertifikata. Hvala lijepa, sretno. Možemo da se